record on this computer. There we go. All right. So I don't even know what date it is today. Today's the 13th. At least it's not Friday. It's just the 13th, right? So it's the 13th, and we're going to talk about pain science, pain neuroscience, and chronic pain today. And like I said, when I was getting set up here, this is a topic that really kind of interests me. And I've already said, I've seen a couple of years, like that's actually kind of interesting to you guys as well. Because we've learned a lot since the days of just, stub our toe, take some Tylenol type idea, or stub our toe, go to the hospital and get some opiates. So we've learned a little bit, and we continue to learn. It's one of the really, kind of leading growing areas when it comes to development in not only the medical field, but also in physical therapy, occupational therapy, and even respiratory therapy type fields. So what do patients want to know? And some of this will come from some books, and I've got some of those books referenced at the end. Some of this comes from personal experience, and then some of this comes from a couple seminars I've taken. So it's a little bit of a blend of everything. So what do patients want to know when they come to see you? Well, they want to know what's wrong with them. How long will it take to treat them? What can they do, to make it better? What are you going to do to make it better? And one of the big ones of late is, does my insurance cover this? Will I miss any family obligations or work, especially work right now? And then how much will this ultimately cost? That's kind of what they come into a therapy visit thinking. And you have to imagine that adding that to all the other kind of problems going on with a patient, maybe they're coming in with multiple sclerosis. So they've got that sitting in the back of their brain. And then they've also got this, will I miss any work? Well, if I miss work, then my kids can't eat. And so they've got this whole cascade of effects going on in their brain. And we have to understand that when they come in, right? So let's look at a patient with low back pain with radiculopathy. So specifically, we're going to talk about somebody with sciatica, right? So let's just use this as an example. So what do we know that's wrong with the patient that's got sciatica? What do we know that's wrong with the patient that's got sciatica?
Could be like some back problems or weak glutes.
Okay. Right, we got some muscle weakness, maybe. We got nerve impingement. Maybe have some tight piriformis, right? How long on average does it take for a normal low back treatment in physical therapy? Not like schedule-wise, but like overall, the total number of weeks and stuff like that to see results. What's like a minimum?
6 weeks? 4 to 6
weeks? 6 to 8 weeks. Yeah, good, right? So minimum 6 to 8 weeks. So what is it that the patient can do? What is it they can do that would make themselves better? What can they do that they can make themselves better? Okay, stretch, good. Exercise, movement, right? And their HEP, good, right? All of that comes into play. They can do all of that and can improve their overall function, right? So that's stuff they can do, right? What are we going to do? What's going to be different from what they do at home? Educate, good. Interventions, good. What type of interventions might we do?
Soft tissue stuff.
Soft tissue, great, yeah. Right, and honestly, I find with low back patients, I don't know if you guys, I saw it, Diana, thank you. I don't know if you guys saw this in the clinic or not, but for as much as we do like traction and e-stim and hot pack and cold pack and whatever, for whatever reason, I think it's because of the human condition, I seem to see they get the best results out of actually us touching them, right? Doing some soft tissue massage. Even if I do very little massage at all, for some reason, they're like, oh my God, that made me feel so much better. And I think it's that human touch component, right? Does their insurance cover this? Well, does that depend? What's the average insurance give us for visits for low back patients? Anyone know what they start us with usually? About? Does anyone have a guess? How many visits we get? What's that?
Lumbalgia.
Yeah, lumbalgia is what we're getting, right? And what do you know how many visits we normally get on an average to start with?
Is it like 10 visits?
Yeah, 10 visits. Yep, about 2 weeks-ish, like 2 full weeks. So about 10 visits is what they give us before we have to do a re-eval and try to justify why we need more visits. So let's think about that, because on that 6 to 8 week scale, we're talking 2 to 3 times a week. 3 times a week is ideal, right? If we can get 3 times a week, man, that patient's going to show us some improvement. So if we get 10 visits, you know, we're talking 3 weeks and 1 visit, and we have to fight for more visits then. So they're not even halfway through their program by the time we have to fight for more visits. And that's not on them, and it may be. Sometimes they do have to petition their own insurance to get more visits, which is kind of sad. Is the patient with low back pain going to miss any work or miss probably some family obligations maybe because of this? Yeah, more than likely, right? Because they're going to wake up some days and just feel crappy. And I can attest to that right now. This is kicking my butt. And the only thing I really want to do, and you see me, and I think about it, I yawn. I just want to yawn constantly. I'm making y'all yawn too, which I love, right? It just kicks your butt. Low back pain, and I know all of you have probably had low back pain at some point in your life. Some of you have it now. It just drains you. So will you miss any work? Probably. Will they miss some family obligations? Probably. So now let's think about this for a second. Let's just say we do 8 weeks of therapy, 3 visits a week. We're going to go with that concept here. So I'm going to write this down over here to the side. So we're going to do 8 weeks of therapy, 3 visits per week. So in 8 weeks of therapy, that means they're going to get 24 visits. Right? What's an average copay right now? Copay or co-insurance? We'll go with copay or co-insurance. What do you guys think? Okay. Yeah, 20 to 30 bucks is about average, unless you look at maybe something like TRICARE, and then it could be up to 75, honestly. But let's just go on the low end and let's go with 20 bucks. Let's say they got really good insurance and it's 20 bucks, right? So that means 24 times 20, right? What do we got there? We got $480. That's for their visits, right? And that's saying that they've already met their deductibles and everything else like that, right? So automatically they're out $480. And we think as clinicians, that doesn't seem too bad to get better, right? But we also have to remember we've got gas, time lost from work, right? Maybe any adjunctive things we add to them. So like creams, TENS units, stuff like that. Anything we add stuff onto them increases that cost, right? And I don't know about you guys, but you know, 480 bucks isn't something that I like to part with. What about you guys? That's something you're okay with just kind of tossing out there? I know it's pocket change for like TJ, but for the rest of us, it kind of hurts us a little bit, right? Yeah, 480 bucks it hurts. So let's change this up now, not change it up a little bit, but let's put them in a clinic now where the clinic looks like this. One PT, 2 PTAs, and 7 techs. Already the clinic's breaking the law, right? But they're being seen by a tech for most of their visit. Maybe the PT or the PTA come over and does soft tissue. Or maybe they come over and they put them on traction or something like that. Put yourself in this patient's shoes now, right? What about that $480 now? How do you feel? Knowing that, and this is a patient that understands. Now, most patients don't understand, but let's say you have a patient that's kind of savvy. Maybe you got a nurse, and she's now receiving care from somebody that's not licensed. What's that value profit margin there? Do you feel very valued? Yeah, expensive, right? You're like, wow, this is not cheap, right? Now let's look at it from, so this is from the patient's perspective, right? So there's looking at it from the patient's perspective. So let's look at it now from the clinic perspective. So let me change colors here real quick. Let's go. I didn't want to change all the color. I didn't know that changed. Okay, fine, whatever. We'll stay with red. So let's look at the clinic perspective, right? So we've got 24 visits. How long are the visits going to be for a low back patient about? What do you think? At a good clinic, what are we going to try to schedule them? At least 30 to 45 minutes, right? So let's just go with 45. Let's say we're a fairly decent clinic, so we schedule them for 45-minute visits. Right, so that means on average, we can bill them about 3 units a visit, right? Let's go with that. So actually, I'm just going to move this to another line because I just want to kind of stress this. So in those 3 units, average for a 3-unit or for a unit is about $20 reimbursement. So that means for those 3 units, the clinic's getting about $60. So now let's take that out and go, we have 24 visits times $60. Right, so 24 times 60, my brain is not working, so let me grab my calculator. So 1,440. But we also have to remember that the clinic on top of that got $480 in copays. So just about $2,000, $1,920 that patient. So a clinic's making decent money, right? That's not bad. Would you say? It's not bad for a clinic. 1 patient over 8 weeks gets you about $1,900. Because you figure there are probably another 10 patients exactly like that. So at least, if not more. So from the clinic's perspective, we making money? What do you think? Yeah, we're making money, right? So we don't really think about what they're thinking. We're just going cha-ching, cha-ching, cha-ching. And especially if you're in a clinic where maybe the PT is incentivized based upon their income. So it's not that I have a problem with this, because I really don't. I think it's okay to incentivize your clinic people based upon the people they bring in and stuff like that. I'm okay with that. But there has to be a limit too, because I think sometimes that was what causes us to get mills a little bit, right? Clinic's doing okay, but the patient's still going, oh man, that just seems a little rough. So how come they're doing it? So, they're out 480, at least out of their pocket, plus other stuff. Now, throughout this whole thing that we just talked about, did your patient have a name? In your head, did your patient have a name? Yeah, right? And I hate to say this, but isn't that real life too a little bit? Our patients stop being Sue and Mary and Truman and Diana, and they just start being our low back patient, our total knee replacement. Right? We just kind of think about that. We don't really think a lot about that. And we forget that human part of the interaction there, right? Just gonna leave that up there for just a second when we move on. So let's look at this patient. So now this patient is a presentation, past medical history. So this patient has had 3 years of chronic lumbalgia, so chronic low back pain. They have a fibromyalgia diagnosis. They've seen 12 healthcare providers in the last 2 years. The pain continues to spread. It comes and goes. The patient has insomnia. The patient has less than 20 minutes of standing tolerance and less than 60 minutes of seating tolerance. This is the patient that when we give them the chart to draw, so here's, you remember that good old chart where it gives them the person? And it tells you to draw an X where their pain is. This is a patient that draws like this, or does one of these. There's where my pain is. Right? Pain screenings are just off the chart. Everything's a 10 out of 10. But now we look at it, patients unable to work or continue Pilates and yoga. Does that give you any insight to this patient? Knowing they're kind of one of their hobbies. Yeah. Right, you're going, wait a minute. What about the 12 healthcare providers in the past 2 years? What's that tell you? Let's talk about it from our perspective. What's that tell us? Anything? They haven't done anything for their long-term goals, right? And so what's the patient feel about healthcare providers in general at this point? Yeah, right. She's coming into your clinic and you're coming to, here comes bubbly old Brooke over to help this patient. And she's like, hi, Sue, how are you doing? And, I know you got eval by Dr. Reskin. Let's get you going so we can help you. And this patient's looking at Brooke and going, the last 5 patients, last 12 clinicians haven't helped me. Why do you think you're going to help me? Right? She's just going because it's required, probably, right? More than likely, she's at this point seeing a surgeon, and the surgeon's selling her on surgery, right? And they're probably selling her, if I had to hazard a guess in this area, they're probably selling her on laser ablative surgery. You guys know what laser ablative surgery is? Has anyone seen a patient that's had it?
Like an ablation?
Yeah, an ablation. Yeah, what do they do in an ablation?
They just kind of burn off the nerves.
Yeah, right. So like specifically like Laser Spine Institute is one of the big ones here in town that does it, right? They go in and they basically burn off the sensory nerve. Does that solve your pain problem? Yeah, well, it does solve it for the time being, Brooke. Because at that point you don't feel the pain anymore, right? As long as they get the right one, which I've seen before where they go in and they ablate off the nerve and they have bladed off the wrong nerve and they have to go back in, right? But for the time being, patients like, man, it gets up, I feel better, I don't have pain, right? But then it comes back with a vengeance, like Joe said. Yeah, right? It's temporary in most cases, and that's not saying that the nerve doesn't grow back as well and comes back angrier, right? So, but she's being sold on this because what's the doc saying? The doc's saying, hey, I'm telling you, I know you've seen 9 physical therapists and they've told you to do this and that and this and that, but telling you, we go in for surgery, you'll be out in 30 minutes and back up. Get some immediate relief. What do you think her medicine list looks like? What are some medicine do you think you're probably going to see on her medicine list? Okay, painkillers, good. Yeah, she's probably on a bunch. It's going to look like a CVS receipt, exactly. She's going to have some NSAIDs probably, right? She's probably going to have, at some point, they've probably tried some corticosteroids, right? They probably put her on a prednisone pack. How about, let me ask you, have you guys seen this med? On any of your patients, Neurontin?
Yeah.
Yeah. What's Neurontin do? Does anyone know?
I don't know. I know a lot of diabetics have it for the neuropathy in their feet and everything.
Yeah, so. Good, Jason, good, right? Neurontin itself is basically, it's a nerve signal blocker. So a lot of patients that have diabetes get diabetic neuropathy because it does slow down that signal, right? And Neurontin is one of those that I found that does work well. Like when I had my fractured neck, Neurontin worked really well for a while. But just like that kind of neuroablative surgery, it starts taking more and more Neurontin. And one of the side effects of Neurontin is it reduces the focus of your optic nerve, especially at really high doses, or at least it did for me. So, I'm sitting there and I'm taking the medicine and I'm taking the medicine and I'm thinking, oh, this is good. This is good. And then, I get a book and I'm like, what does that say? Because I could barely see what's in the book. And some of you are going, that's the way I am now. Well, yeah, true. So it does affect things, but for the short term, it can be useful. Now, could that neurotin help us in physical therapy? Gabapentin is the name of it. Yes, you're exactly right, Stephanie. That's the generic name of it. Could that neurotin help us in physical therapy? Yeah, right? We could use that benefit of the neurotin for the time being to hopefully get them better. We're missing one other major class of drugs she's probably on. What other class of drugs? Yeah, there we go. So Flexeril, Soma, all those fun ones, right? So she's missing muscle relaxers. She's probably on some muscle relaxers. And most of the Flexeril and Somas are going to be central nervous mediated. We're going to talk about that in pharmacology. Excuse me, I got the hiccups down. So the goal there again is very much like the neurotin to kind of slow down the signals. Yeah, what are the side effects? Sleepy. That's the major one. So now let's think about this for a sec, Steph, because you brought up a great point. So now she's neurotin, maybe not so much the sleepy effect. Flexeril and Soma, sleepy effect. Now she's on, let's say she's on an OxyContin 10. What's the side effect of OxyContin? Sleepy. Constipation too, right? So now she's on two meds that cause her drowsiness, right? So she may not be 100% there when she comes in to see you, right? So she's on all this polypharm in order to treat these symptoms. And she's coming to you going, man, like nothing's working. I don't know why I'm even seeing anyone, right? She probably has not only a regular doc, she probably also has a pain doc, right? Because she has fibromyalgia. And now don't get me wrong, some pain docs in this valley are really great. And then some of them, not so much. So Stephanie asked, are the patients allowed to drive? Technically, no. Right? Because what that be, if they got pulled over, technically, what would they get called for or get nailed for? DWI, yeah, right? Typically not DUI, they'll usually hit them with DWI when it's medications, which is good. Because DWI is the lesser of the two charges, right? Whereas DUI is usually the felony, but they'll get hit with that, right? And now but just like a functional alcoholic, do you think she's walking around with most of this stuff being fairly functional? Anthony would take her meds and Anthony would be out for a week. He'd be getting a nice, comfortable sleep. She's walking around with that because it's not helping her, right? So let's take a look at these questions from a different outlook. Instead of looking at it from our traditional outlook, let's look at it from a pain neuroscience outlook. And let's change some of these questions up. How about instead of saying, what's wrong with me, we change that to, why do I hurt? Does that change the context of that question? Are you able to better answer, why do I hurt, versus what's wrong with me? Because what's wrong with me means something is inherently wrong with me, right? I am broken. And some of you are going, yeah, I'm broken too. No, that's not what I'm talking about. But why do I hurt? We can answer that. We can do anatomy on why they hurt. We can't do a real anatomy on what's wrong with me, right? Let's mute my phone. And instead of how long does it take to treat me, let's look, will I get better? Will it ever get better? And is there any hope? Because reality, that's what's in her head. It's not necessarily how long will it treat me. It's, am I going to get better? Is this ever going to get better? Am I going to get back to Pilates? Right? Give me some hope. And some of us, because of our bubbly personalities, will be able to give this patient a little bit of hope just from the way we talk. I unfortunately am not gifted with that ability. I'm a little bit gruff and short and kind of mean. But I've seen and I've talked to some of the clinicians you guys have worked with, and a lot of you, some of the patients really loved you. And why do they love you? Well, it's not necessarily that you're the best clinician in the entire world. You may be. I'm not saying you're not, but it's not necessarily that you're the best clinician in the world. A lot of times it's because you listen to them. Right? I'm sure some of you had patients that came in and they just didn't shut up the whole visit. They just went the whole way through the clinic. They're doing lap pull downs, their mouth's moving, right? And so even by just doing that, you're helping them feel like there is some hope, right? And then we got to look at what can I do to make it better and what can you do to make it better? Because those are the two things that they really want to know from us, right? So what could we have done? We could have done spinal mobilizations. We didn't mention that, but definitely that could be an intervention we do, right? And which one of those spinal mobilizations are we allowed to do? Good. Trick question. Excellent job, Stephanie. None of them, right? So PTAs, no. PT, sure, right? But no for us PTAs. Lumbar traction. Oh, let's take a trip down memory lane here with this. We're going to do lumbar traction on a patient. What do we need to know about the patient in order to effectively do lumbar traction? Wait, all right. So let's say this patient is 200 pounds. Okay. What are the two main types of traction? So going back to almost like ultrasound here again, what are the two main types of traction you can do if we're doing on the machine? Static and what's the other one? Goes with static. Intermittent, good, right? So we could do static or we could do intermittent. I know, I'm taking you guys back to modalities here. But this class is designed to help you remember about all this stuff so you can prep for the board, interim. I know I'm going to spell this wrong. It is an E. I know it is. I've always spelled it wrong. All right, so we can do static and intermittent. Do you guys remember which patients you do static with and which patients you do intermittent with? I spelled it wrong. I told you. I knew it. Okay, disc bulges for which? Or is it for both? What patients do you remember? Let's go this way. How about this? What specific class of patients do you want to do static traction with? In what phase of healing? One specific phase of healing. Good. Okay, so that's also the inflamed, also known as the what phase? Acute. Yeah, right. Now, it doesn't mean we can't do static, and there aren't static reasons to do with other patients as well. But for your board's perspective, I guarantee that'll be a question you may get on your boards. Okay, is that for what patient is static traction primarily indicated? And they are the acute patients. Why would you maybe not want to do intermittent with an acute patient? So intermittent's going to pull and relax and pull and relax and pull and relax. There you go, Joe. It's aggravating, right? It's going to kick up that inflammation that Diana talked about, right? So usually we're going to hold that nice static pull, right? And also when they're in that acute phase, our pull levels are going to be lower, right? We want to start off a little bit lower on that acute phase and then maybe build up as we go through the treatment. What percentage of the body weight can we do in traction? Where do we start? Okay, 50% is about where we start. Good. Does anyone remember what we can go up to? Believe it or not, we can go up to 90% of their body weight. Now, ideally, in most clinics, they'll say 70. And for your boards, I believe it is 70. But most research shows we can go up to 90%. And again, mainly because it's going to take, I think it's 485 pounds of force. If I'll look it up when we're on break. I forget the exact force is that it requires in order to truly separate the spine. So unless you have somebody that's, 600 pounds, the likelihood of hitting that separation of the spine is really low. So for your board, 50 to 70% is a good rating, right? How long do they need to be on the traction for it to be effective? What's the minimum? What's the minimum for all your modalities? Let's go there. 15. There we go. So for your boards, your safest bet with modalities is 15 to 20 minutes. Because 15 is technically the safest. Now, in the clinic, what are we going to do? So Brooke and Joe and John are all kind of, and even Anthony are all kind of right. We're probably only going to do 8 to 12 minutes, right? Just because that's a billing unit. It's just honest, right? Yeah, at least 8 so we can bill, right? But 15 to 20 is where we want to be. And I've seen a new trend in the clinic. So understand for traction, we get, again, just like ultrasound, we get 1 minute setup and 1 minute of tear down. So if you do the traction for 21 minutes, what does that mean? If you get 1 minute of setup and 1 minute of tear down, you can now get what? 2 units, yeah, right? See how that works? I mean, that's, and I've seen some clinics where just like ultrasound, they'll do like 6 to 7 minutes of traction, which does nothing. So don't do that. That does nothing for your patient, right? So we got her in traction. What position are we going to put her in for traction? What are our 2 choices for positioning? Supine and prone, okay? I don't know if Dr. O'Neill covered this with you guys when she talked about modalities. Which of those have the research shown gets the best results? Yeah, you can do sideline. It's really difficult though, Diana. Prone and supine are the easiest. Sideline is really, yeah, believe it or not, prone has been shown, and Diana, don't scratch that totally. I have done sideline traction with the patient. It just is a pain in the butt to set up. And there's a whole way to set that up. It's just a pain to set up that way. But prone has been shown to have the best results. Well, why do you think that is? Let's think anatomically why prone might be a good way to do it. What'd you learn from Dr. Vreskin when she talked about the spine? Yeah, back as an extension. There you go. Good, right? It decreases lordosis and you get that little bit of extension going on. Even if you're just laying flat and prone, you've still got a little bit of extension, so those facet joints open up a little bit. So that makes it easier to pull them apart, right? And it also, yeah, I feel that you're also more relaxed. I think so too, because when I'm on supine, I'm staring up at the ceiling, and usually the clinics have those bright fluorescent lights, and they're glaring down in my eyes, and the clinician forgets to turn those lights out in the room. And so then I'm sitting there and I'm staring at the ceiling and I'm contemplating my life choices, and just isn't a good thing. But sometimes we can't lay prone. Sometimes it's because they have bellies or whatever it may be, or they're just not comfortable in prone. We have to do supine. But remember, one of the things, if you look at your traction, so here's my traction machine, right? And here's my mat. And here comes the cable that's attached into the belts, right? So there's the belts on the patient. And here's the belt holding them in place. One of the things we make a pretty big mistake on is because we've kind of lost this art in physical therapy is, and I don't know if I'm hoping some of the clinics still do this, but depending upon what angle you put this belt at, so in through there, what angle you put that belt at will determine how far up the spine you're actually pulling. And there's actually a whole formula for that. That when you put the belt at this angle, it's pulling primarily at L3, L4. If you put the belt at this angle, it's pulling at L2, L1. Did any of you see that in your clinic?
Not the formula, but we have like we had a high-low chair, so we just had to make sure that it's pretty even too.
Yeah, what most people do is they just put them on all the way up and just have the cable pulling straight.
Yeah.
Right? And that's ideal for prone traction. If you put them in prone, then you just put the cable straight and it pulls because it's pulling the whole spine. But if you ever look, and so the next time you guys are in a clinic that has traction, right? Look right where that cable comes out of the machine. If you look, there's going to be angle marks. And those angle marks indicate how far up or down the spine you're pulling. And I'll see if I think I've got the chart on that in my stuff. It's been a while since I've done low back traction, but I'm pretty sure I have it in my clinical binder for myself. So I'll look over on the shelf on break for it. But it's actually interesting, and we found that if you do it, and again, is that going to be 100% only pulling on L2, L4? No, it's going to be pulling more than just that, but it kind of targets that area better. All right, we covered traction ad nauseum now.
I got a quick question though.
Yeah.
So, if our goal is to put this to put the spine in an extension, or at least slight extension, I've seen some of the clinics when they do put people on traction. There's we prop their legs up, but doesn't that kind of then take away the extension?
It does, but the goal at that point is to get their back as flat as possible.
Okay.
So their goal for that is to increase or decrease the lumbar lordosis.
Mm-hmm.
So it's a trade-off for being supine.
Yeah. Okay.
Yeah. Good question. Yeah. Good question. All right. I should have just clicked clear all. That would have been easier than erasing, but I like having an eraser. Makes me feel powerful. I have erased the world. All right, spinal stabilization program. We're going to teach her lots of stuff, right? We maybe do directional bias, right? Probably. And modalities adjunctive to that, we're probably going to do some TENS or some IFC with her because it's feel good stuff. She's probably going to go on hot pack when she comes in and then go on cold pack when she leaves because that's what we do. I really like to put the patient on a hot pack when they're on traction, to be 100% honest, if I can, mainly for two reasons. I can't bill for the hot pack anyway, right? Hot packs are usually non-billable at this point for most insurances. So I can throw her on the traction and get both out of it and get them both knocked out of the way, and I have more time to treat the patient. But we're going to do some modalities with her probably, right? And if she's, one key thing, if she's on either of these programs, either the McKenzie or the William program, right? And your PT has her going into extension, when do we add flexion? Yeah, we don't. Correct. Yeah, unless the PT says we're okay, we're ready to go into flexion. Right? Just be aware of that. And especially if your PT is McKenzie certified, they will get kind of testy if you suddenly add flexion. But you also have to think about that because I've seen clinicians that are like, oh, well, I didn't add flexion, but I added double knee to chest. Because they think a flexion is just straight like this, right? Bending over. But double knee to chest is flexion, isn't it? Because you're flexing the trunk, just reversing the kind of that flexion. So you have to think about what you're doing. All right, so then we're going to start digging deeper with this patient. What do you think the patient knows about back pain? Probably not a whole lot, right? But where do you think she's got all her information about back pain? Where did she go for answers? WebMD, you're right, right? She went to Google. Dr. Google is helping her. So then we have to figure out, does the patient even want to know about the back pain? And then what can we educate her on? Do you think the patient might be a little bit scared of learning the true cause of her back pain? Why do you think that might be? Good answer, Raquel. Why do you think that might be? What could lead to that fear? Excuse me, sorry. Well, a couple things. Because, yeah. She doesn't want to challenge her lifestyle, good. Maybe surgery or long-term, good, right? Could it also be that she realizes she caused it? Right? Think about that for a second. That could be really kind of traumatic, realizing that you have the problem you have because you caused it. Right? So she's probably got a little bit of fear there, right? Even with the clinician, oftentimes we're a little bit afraid to find the true cause of the back pain, because sometimes when we find that true cause, we realize we can't treat it. You know, patient comes in with a complete window closure of the spine because the lateral aspect of the vertebral body is collapsed. There's not much we can do about that. We know that. The only thing we know at that point is they're just coming to physical therapy because their insurance requires it until they can get surgery. So sometimes we're even afraid of it. So how about you guys right now? How confident are you guys in your skills to treat a low back patient? I'm assuming those of you that went to outpatient probably a little bit more confident. What do you think? 6 out of 7 out of 10, okay. A little, where would you rate yourself out of 10? And be honest, I'm not judging anyone, and no one's got the wrong answer. So we got 5 out of 10, 7 out of 10, 6 out of 10, right? Okay, good. So those of you that are going to outpatient, I would hope that after your next clinical rotation, you're closer to an 8, because this is going to be one of those that, for those that are 8, huzzah, right? And mainly the goal for this back patient is going to be following the plan of care for the PT, right? That's going to be most of our job. So what can we change about the patient's view on pain? Well, we can change the cognition of the patient, right? And by changing cognition, I mean helping her understand what triggers her pain, what makes her pain better, and how she can avoid triggering effects, right? So she already said she can't sit for long. Right, she's almost got no sitting. I mean, she's got no standing tolerance. She's even got really low seated tolerance. Right, so we're going to have to work on her and changing her cognition, that she understands when she needs to get up, when she needs to sit down, when she needs to move, when she doesn't need to move. Are we going to fight the beliefs on this patient a little bit? Because she's coming in believing PT sucks. So we could be the best clinicians in the world, but we're going to be fighting that little bit of a battle of, does she believe in us? We're also going to work on the fears. You think she's going to be a little bit, trust is key. You think she's going to be a little bit afraid to do a prone press up maybe the first time? Yeah, right. Especially if we're doing something like where we're doing bias training, where maybe we know that she's got a bulge on the right side, so she's got to do a prone press up with a little bit of rotation, because that's going to, or be this way. There we go. We have to get her to buy in. Now, some of you, again, I'm going to say it, some of you have an advantage because some of you have that face that just people like. I happen to have one of those faces that people just want to punch. Right, so a lot of you have that, and that's one of the advantages you guys will have, is you guys have that the young face, that exuberant face that patients really, especially older patients, right? The older patients tend to really, for whatever reason, kind of like the younger clinicians. I don't know if it's like a grandfatherly thing, grandmotherly thing, or if it's just that you guys are less jaded than people like me. Maybe because they're so jaded, they like you guys. But yeah, we're going to have to get them to do it. But the key thing is, if we don't change these objects, then going to physical therapy, we're already setting ourselves up for failure. Because if she doesn't trust us, if she doesn't believe she's going to get better, if she's constantly afraid of doing things, what is the chance she's going to do her home exercise program? On a scale of 10, what do you think the chances are? If she doesn't believe in us, she's afraid, 0. maybe a 1. We'll give her a chance. She might do one of her exercises. She likes doing pelvic tilts, except she's doing hip thrusts instead of pelvic tilts. And all of you have seen that, right? They look like they're bucking in the air. So we'd have to modify this before we get into therapy. So with the pain effect, right? Cognition comes into play here. We've demonstrated that cognition and pain are not just related, but really, 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 I don't know why I put a question mark there. I just like putting question marks, I guess. But we've demonstrated that pain and cognition are clearly intertwined. There is a lot of benefit to understanding your pain. But the downside is that can also increase your fear. And then the patient can catastrophize the condition. They can make their condition worse by taking on their condition. Right? What about the patient's social circle? Can it make it better or worse? What do you think? Their family, their friends? You think it could make it worse, right? I've seen it that it doesn't make, and the only times I've seen it really that makes it better is, right, depends on the beliefs. I've seen it where, you know, grandma is coming to see me now in physical therapy, and I had treated the daughter for her total knee replacement and or ACL repair or something like that. And the daughter had phenomenal results with me. And now grandma comes in for low back pain, and automatically her daughter's like, look, you can trust him. He's going to help you. And so that helps build up that trust. Right. But then I've also seen it where family doesn't. Right. Well, you're never going to get better, grandma. So just kind of get over it. And the internet definitely is going to affect the patient. Right. They're going to be watching YouTube videos, like somebody said. They're going to be watching WebMD. They're going to be going to every single site that's out there. And they're going to question, and they'll sometimes come in and say, well, why aren't we doing XYZ treatment? Did anyone encounter that at all in their clinic? Where the patient came in and said, hey, I saw this. Why are we not doing this? Like the one I encountered last time I was really treating outpatient was they're like, well, I saw that blood flow restriction is really useful for treatment. Why aren't we doing the blood flow restriction on my low back?
We had a patient come with an entire home exercise program sheet that she printed up from some website.
It's phenomenal.
And we were like, well, then just do those at home and we'll keep doing what we're doing here.
That's phenomenal. That's great. Here, I made my own, I did my homework. I made my own exercise program. That's when you go through and go, okay, yeah, no. That's great. But I had a patient come in and ask why we didn't do blood flow restriction on the low back. Yeah, sometimes once you scored. But let's think about that for a second. How are you going to do blood flow restriction on the low back? That was great. I kind of had to chuckle at that one. That's going to be one heck of a pressure cuff. But yeah, so, and then the multiple clinicians are also going to affect it, right? Yeah, blood flow. I wonder if anyone's ever tried, like, thought about that. Like, I imagine somewhere somebody's like, let's try blood flow restriction for cervicalgia, and they put the cuff around the patient's neck. I'm sure somewhere somebody's tried that. And let's say this patient has come seen Mr. McKeever before, and now they're coming to see you. The way that I treated them is also going to affect the way they look at you. And that's a sad reality. Or, you know, just like I saw, you know, today when I was, by the time I got up and got tested for my nasal swab and they probed my brain, because literally that nurse was just, she was going to town in my brain. She was trying to lobotomize me. What do you think? Let's say if I had left that place and gone to physical therapy, what do you think my attitude towards healthcare providers is like now? Just going for that test and now going to physical therapy. I shouldn't be going anyway, but in general, is that going to affect my view of that physical therapist, even though that physical therapist has nothing to do with it? Yeah, because they just group us all into healthcare, right? How many of you guys So how many of you guys have ever gone shopping for a car? Just curious, like to a dealership and stuff. Anyone in here? It's the worst, right? Right? How many of you have gotten that old school car dealer? The guy with the slick back hair, you know, I'll talk to my manager, that type guy, right? The worst. And now, I'm speaking from experience because I sold cars way back when. But now let's say you get a dealer, a salesperson that's not like that. Do you still have that unconscious bias towards that person? Oh no, you're one of them, exactly, right. Right, you're walking on the lot and you see, I don't know, you're out looking for an SUV and you're walking on the lot and then you hear from behind you, is there anything I can help you with? Do you internally cringe? Yes, like, yeah, here we go, God. And what do you say instantly? What's everyone say instantly? I've been on the left, just looking. Right? Even if you're there to buy a car, you're just looking because leave me alone, right? That comes into play in healthcare too. Previous healthcare practitioners bias the patient towards new healthcare practitioners, right? So we have to be aware of that. And we may not be able to do anything initially about this, right? Initially, we can't fix this, but we have to build that trust, like John said, right? They better not be coming to physical therapy to just look around. All right, so let's look at fear. So the Merriam-Webster Dictionary describes fear as an unpleasant, often strong emotion caused by anticipation or awareness of danger. Dr. Google says unpleasant emotion caused by the belief that someone or something is dangerous, likely to cause pain or a threat. Wikipedia says it's an emotion. Hey, we cause pain, exactly. An emotion induced by the danger of or threat, which causes physiological changes and ultimately behavioral changes such as fleeing, hiding, freezing from perceived traumatic events. Fear in human beings may occur in response to certain stimulus in the present or in anticipation or expectation of a future threat as perceived as a risk to oneself. The fear response arises from the perception of danger. So key word there, arises from the perception of danger, leading to the confrontation with or escape from avoiding that threat, also known as a fight or flight response, which in some extreme cases of fear, horror, and terror can be freezing paralysis, right? The key thing here that I thought Wikipedia was had an interesting addition is that in humans and animals, fear is modulated by the process of cognition and learning. Thus, fear is judged as rational or appropriate and irrational or inappropriate based upon the way we see things, right? An irrational fear is called a phobia. Do any of you have any phobias where you're afraid of certain things? Anyone got heights? Okay, Joe's got grasshoppers. I haven't heard that one. That was that 2 years ago when we had those grasshoppers all over the state. That had to be weird for you. Like I remember having those swarms downtown, centipedes. You're the dentist. Yeah, actually, Sydney, I'm right there with you. The dentist is probably the one thing that I get the worst. So many centipedes in Reno. Are they hairy? Undergrad psychology. Yeah, they're just weird. Hairy centipedes freak me out too. Though I'm not necessarily afraid of them, but they're definitely weird. There's a lot of phobias that exist out there. That's where they held me down. And I've done it ever since. Exactly. That's, well, for me, it was I made the decision to get a cavity drilled out, or actually a tooth pulled without Novocaine. And that pretty much has ruined it for me. Scared of pickles. That's phenomenon, right? There's probably a name for that, Truman, I'm guessing. Pickle phobia or something. Why do we get these phobias? Well, like Sydney said, a lot of it is a learned behavior. Right? We develop an irrational fear for things because of the way we might encounter things. I hate spiders. And why do I hate spiders? I remember when I was younger, one day, I remember I was sitting reading in my bedroom, and I watched this big spider come down from the ceiling, and I wasn't scared of the spider. But then I killed the spider because it landed on my bed. And when I killed the spider, I didn't realize it was a mommy spider carrying thousands of baby spiders. And suddenly my bed was just infested with little baby spiders. And for like a week, I could not sleep on my bed. Yeah, there is one answer. It's blowtorch. Yeah. Now, did those spiders really cause, I mean, let's face it, did those spiders really initiate any or cause any threat to me? Not really. It was just a common house spider. Well, I don't even know what kind it was, but it wasn't brown recluse or, a black widow or anything like that. It was just a normal spider. Probably an orb spinner or something like that. But I developed an irrational fear of them for a while. And to this day, it's not that I'm afraid of spiders, but spiders must die. Pretty much anything with 8 legs, because scorpions get in there too. But it's from cognition and learning. And to me, that's kind of interesting. Any bug must die. Are you one of those that jump up on the table when you see a bug, Bianca? I called that. I could have let them bite me to get superpowers or gone to the hospital like the guy from the Liberty Mutual commercial. Oh, Sydney, birds need to chill too. Yeah. I've only ever been afraid of birds once, and I'm trying to remember where I was. I think I was in Baltimore. And for whatever reason, we're going through this. They're just birds are spiders. There's a whole, by the way, John, there's a whole conspiracy on that. If you haven't looked that up before, there's a whole thing that birds aren't real. They're just drones. But you'll get lost in that for hours. Have you ever seen a baby pigeon? Exactly right. See, these are things we encounter, right? For me, I walked in, I remember I was walking across this like courtyard or something in Baltimore, and it was literally a scene from the birds. Every single inch of everything up in the air was covered with black crows and blackbirds and ravens and like the only thing I could think of at that moment was the movie The Birds, that these things were going to come down, swarm me, and eat me alive. In reality, they're just like chilling there, like hanging out. They weren't going to do anything wrong to me anyway. It was just funny. Snakes for me are another one that I don't like snakes. Yeah, I really don't like snakes. Not afraid of them, but definitely don't like them. But yeah, so how do we overcome that fear? Snakes on a plane in particular, yeah. And then sharks with laser beams. Got to watch out for them. Yeah, we face them, right? You're exactly right. You do have to face them in order to overcome it, right? How many of you guys know somebody that's a friend or whatever that has a fear of commitment? Maybe you're going, Mr. McKeever, why did you just call me out? I'm shook. I don't know if you do. It's me. I'm the friend. And why is that? Well, it's because we've learned behavior that causes us to fear that. Right? I'm going to be honest. I had fear of commitment. Unfortunately, I didn't escape it. Just kidding. I love my wife. I think she loves me. Hold on, should I ask her? What did she just text me? She just texted me that a patient that she's seeing put down that they're allergic to penicillin. That's great. I faced it. Yeah, I walked down the aisle. I didn't look that great in the tuxedo. Let me tell you, I've got to lose some weight. I'm not happy with those pictures. But yeah, so, you got to imagine. So I'm just to put this fear in perspective. I'm afraid of sparklers now. I am terrified of sparklers after getting my head burned. The little great grand aunt that decided to crown me. But you have to understand from my perspective a little bit, because I'm just going to use this as an example for fear. From my perspective, I was married. And I was in a long-term relationship. My wife got really sick. And so when she got really sick, I had to take care of her. And then as I took care of her, she got worse and worse and worse and eventually died. Do you think that puts a little bit of a damper on getting into a relationship? I know I'm making you all cry. No, I'm just joking. No one's crying here. Yeah, it definitely negatively affected me. And it took me a while to propose and do anything. And you guys probably didn't even know I was dating somebody, because I kind of keep my personal life a little bit personal. But she's a great hand therapist, I have to say. Like, I remind her of that every day, that she's a phenomenal hand therapist, because God love her for doing hand therapy. And she's going through terror right now herself, because almost all of the PTAs and all of the front office staff at her clinic is out with COVID. So, but yeah, fear. I have a fear of COVID right now, guys. I'm going to be 100% honest. This is round 3. I don't want round 4. I'm getting tired of this. Now, part of it is because of me, but still, I don't want round 4. So how do we quantify fear? Well, in the physical therapy world, we do have what's called a fear avoidance beliefs questionnaire. There's the Tampa scale of kinesiophobia. What is kinesiophobia?
Fear of movement?
Yeah, fear of movement. Bet you guys didn't even know that existed. But there is one, right? There's other things we can put off the shelf, like the lower extremity functioning scale, the low back disability quantity index, the Oswestry. We can do cognitive-based interviews with the patient where we have them talk about their fears. But why would we want to quantify the patient's fear? Because it helps us understand it. It helps us give an idea of what their pain in their head looks like. Because the greater the patient's fear of therapy, the harder it's going to be to win them over. So here's kind of what happens with the patient. And this is where we'll do this and we'll take a break here. So patient starts here, right? Patient gets an injury. That injury leads to a pain experience, right? So let's say you're out playing soccer and you tear your ACL. You get a pain experience. Suddenly you start going on WebMD, YouTube, all over the place and watch stuff. And you take on a catastrophe of that injury, right? So like, oh my God, this is horrible. I tore my ACL. God, am I going to be able to walk again? Am I going to be normal again? So then you get over here and you start forming this threat perception and a fear of pain. So you start getting this fear avoidance effect where you're like, okay, well, because it hurts when I walk, I'm going to stop walking, or I'm going to walk less, right? Well, because I walk less, I start taking on a little bit of a disability. Now that I have a disability, I start getting depression. And then I get up and walk with all of this, and I get a little bit more of a pain experience. Yeah, right? The patient just gets stuck in this circle, and it just keeps getting worse and worse and worse and worse. Where we come in is we've got to come in and give them an exit. So we got to put them on. So, you know, if they're on the highway of pain, we've got to give them the exit to get off that highway of pain. And we've got to lower their fear. So we've got to convince them that pain is normal, right? Pain is, I hate to say it, like the good old adage, pain is life. But it really is. It's a part of life. We have to acknowledge it. Say, hello, pain. It's nice to see you again. Right? And we give them this exit to lower their fear, right, of that pain experience. if we can lower that fear, we can help them confront their concerns. And then once they confront their concerns, they can actually recover. And believe it or not, this is not that different than the cycle that an addict goes through from a psychology perspective. This is all not all that different. You know, so instead of an injury here, you have an experience of a drug. Right? So maybe it's heroin, maybe it's cocaine, who knows? And instead of a pain experience, you get a pleasure experience. And instead of catastrophizing, you start glorifying it. But you still didn't get over there that area where you have the fear of what happens if I'm not on that drug. So you start avoiding it, so you start taking more drugs. And because of that, that whole cycle of disuse, depression, disability comes in. And so you start taking more drugs to get that pleasure experience again. It's the same cycle. So what do you think? Do you think pain might be a little bit of a drug? Yeah, it might be, right? At least in the perspective that it's it could be a second habit, right? At least in the idea of thinking that neurochemically it's a drug, right? Because we know that when we experience pain, we have certain neurochemical results of pain. And it may not be the same center. It's not your pleasure center lighting up, right? With pain, definitely not. Although some people, they're actually pleasure centers do light up with pain. But we're not talking about that today. That's a totally different topic. But yes, it's, and a little bit of people, did any of you encounter a patient in the clinic that their pain is kind of their personality? Yeah, right? And in that way, I don't look at it much different than an addict, right? I've encountered people that for some reason injure themselves constantly so they can constantly be in kind of a state of suffering. It can be an attention thing, exactly, Brooke, right? Especially if they're not getting enough attention in their life. Limping for no reason, I love it. And we have to convince them that it's okay to be in pain. It is. Like, I'll tell you guys right now, it is okay if you have pain in your body. Trust me. I'm I'm loving the chest pain I've got right now. It's loads of fun. I am in pleasure from it. I'm really not. But here's the deal is I could easily get caught in this, and I understand pain. Right? It would be really easy. I'm going to be 100% honest with the stuff I've been through as far as like breaking my neck and stuff for me to be on disability. I'm pretty confident I could fill out the disability forms and get approved first time around. You know, I put that I have no sensation in my left arm, that I have atrophy in my left arm. I've broken my neck twice in my life. I've got 2 plates on my neck. Pretty sure I'm going to get approved for disability. Right? And I could have easily just got stuck in this vicious cycle with everyone else. And this is why this is an interesting topic to me, because this topic came to me at the exact right time. And it was almost like providence. I don't believe in, you know, faith and all that stuff, but I think that it's very much that it came to me at the right time. That I needed something to study when I was sitting at home and couldn't do any therapy. So I started studying pain and how pain works. And I really think that's why I was able to go back to work, is because I was like, wow, okay, so, you know, it's okay to be in pain. It's also okay to take 90 oxycodone a day. I'm just joking. I didn't take 90 oxycodone a day, only 80. But do you see how this could kind of gets people trapped? Right? And so we've got to be over here with this exit. We got to give them that exit out. But in order for them to take that exit, what has to happen in their mind? They have to what? They have to normalize pain, right? They have to want out, yeah, right? Because like some of you are like, yeah, I saw some patients that was their second habit and stuff like that. They have to want that ability to get better. And if we just give them generic goals in physical therapy, they may not want to get better. So we have to, again, personalize their therapy for them. Take all my scribbles off here. All right. Let's take a break here. This is a pretty good place to take a break. I'm going to pause recording. All right. And we're back. Let's continue talking a little bit about pain here. So same kind of concept here. This is just a little bit clearer of a drawing than that last one. But same idea. And the one thing this one adds is where in that pain catastrophizing method, they start getting a negative affectivity towards it, where they start kind of taking on that pain. And that's where they start finding out more information about their pain. And again, that vicious cycle just keeps going. So this actually is looking at more of a child type experience. And I thought this was interesting because if you look at this, the child itself actually has both more escape routes than adults, but also has more ways to cause it to get worse. And this is true. So let's look at a kid real quick. So a kid experiences pain. The child experiences the pain, right? Now, the child can accept it, confront it, and move on, right? They can express pain. The parent can interpret it, right? How many of you have ever seen this before in the world where a kid like falls down a whole flight of stairs, sits there, no one makes a noise, the kid gets up and runs off like nothing happened? Maybe it's not falling down a flight of stairs, but maybe it's right. Or you see a kid that stubs their toe a little bit, and mom goes over and goes, "Oh my God, my baby, what's going on?" And what happens? And then, yeah. And then the tears just start rolling, right? Yeah, you're like, "Oh, you only lost a hand, you're fine." My dad had a different method of that, Riley. It wasn't, "Oh, you're fine." My dad's method was, "Do you want me to give you something to cry about?" "No, I'm okay." But yeah, so depending upon how the parent does stuff with children can determine if the child kept. That was fun, yeah. But it's true though. The parent has a lot of effect on how the child then interprets pain in the future. And not only that, but babies and children can also learn behavior from the way their parents interact with them, right? How many of you guys have seen that kid in the shopping mall or at the grocery store that is screaming because they want Fruit Loops or something like that, and the mom just gives in, or the dad? I'm not gonna be sexist here. Or the dad just gives in, or the non-binary gender parent just gives in. I don't even know what to say anymore. The family member gives in. There we go. Thank you. Right? So the family member gives in. What's that kid learn? If they screamed and got what they wanted. Yeah, cry and get to what you want. Yeah. And initially, when we're a baby, right, we typically cry only for a couple reasons. Oh, that's fantastic. For instance, my brother used to threaten putting his finger down his throat. Yeah. My brother had a similar thing, except my brother was, "I'm going to hold my breath and then I'm going to die. And then you'll feel bad. So you better buy this for me." And I remember my mom the one day is like, "Go ahead." Because she knew that if he held his breath long enough, what's going to eventually happen? he's just gonna pass out and start breathing again anyway. Yeah. But it was just funny. Like that was his threat all the time. Or his other threat was, I'm gonna run away. That was my other brother's. If you don't buy me this, I'm gonna run away. I got lifted him off for having a tantrum. Never did that. I'm trying to think what did I usually got work for having like getting upset. Like my dad was famous. I'll never forget the one day when I was a kid. It was I want to say it was like 6th grade or 7th grade. I got dropped off at the police station. That's fantastic. Good parenting going on here. But I remember I was a summer vacation and I was sitting in the living room and I'm like, I'm so bored. You know, kids like that, right? And my dad says, well, I have a project for you. I want you to go out to the backyard. And he took out a sheet of paper and he drew this up. And he's like, I want you to dig me a hole that is exactly 6 feet long by 6 feet wide by about 9 inches deep. And I need you to put it here in the yard. And so I went out and dug the hole, not really wanting to. And I came back in and I said, hey, I dug your hole. Now what do you want me to do? And he goes, go fill it back in. And I'm like, well, why? He goes, well, I bet you won't complain about being bored again. I learned to pick up books. I started walking home. I like this. We've all had some borderline scary parents here, so I'm seeing. Not necessarily abusive, but definitely some scary parents. I think mine was borderline, but we'll leave that out here. But yeah, so the way the child interprets fear often has to do with the way parents interpret fear, right? And pain. So there are all kinds of consequences that can occur from pediatrics encountering pain. So here's kind of that pain and everything getting lost in this roundabout, right? I don't know why, gosh dang it, England, why did you come up with these stupid roundabouts? And then we adopted them here in the United States. I don't know about you guys, but like I see one of these and instantly I cringe. I hate roundabouts. I don't know why. So what does it mean to catastrophize something? Well, the Merriam-Webster dictionary says to imagine the worst possible outcome of an action or event, to think about a situation or event as being a catastrophe or having potential catastrophic outcome. Dr. Gould says to view or talk about an event or situation as it's worse than it actually is, or as if it was a catastrophe. Oh God, some of the kids I treat, they're that way. Mom, I want to play Fortnite. You're ruining my life because I can't play Fortnite. Yeah, that's definitely a catastrophe. In psychology, we have a term for this called cognitive distortion. It's an exaggerated or irrational thought pattern involved in the onset and perception of psychological states, specifically those more influenced by psychosocial factors such as depression and anxiety. Right? This is where you see things not like they are, and you get this cognitive distortion going on. Some of you may have had cognitive distortion for me when you first saw me as an instructor. You know, you saw me and you're like, oh my God, that's a big scary guy that's going to be mean to us. Oh, this is going to suck. And then you didn't realize how awesome of a teacher I am. And now that cognitive distortion has changed. So thinking the worst, exactly. You know, not only thinking the worst, John, but also expecting the worst. Right? Because thinking is one thing, but to expect it is a totally different thing. And that can be a way of life eventually. And we probably all have that one friend that's like that no matter what's going on in the world, something's going to get worse. Your mom, right? I'm going to be honest, I suffer from this a little bit because I'm just like, oh God, the stupid just keeps going on. Anxiety attacks, yeah, right? And the things that people can suffer anxiety attacks from still to this day amaze me. I was actually, now that you mentioned that, John, so I was just the other day, or was it last night when I couldn't sleep? I can't remember. It's all hazy at this point. So I'm not sleeping well right now, if you can't tell. I was watching Iron Man 3. Have you all seen Iron Man 3, or most of you seen Iron Man 3? Right? Right? Some of you are like, yeah. Bianca's like, I don't watch those films. No. So if you've seen Iron Man 3, you have seen somebody with cognitive distortion, right? In that movie, yeah. Yeah, she doesn't watch superhero movies, I don't think. Or maybe she's just a DC fan. We'll just go with that. Maybe she's a DC fan. And if DC could just make one decent movie, that'd be really appreciated. They're animated movies. Yeah, that's what I thought. Okay, never mind. So in that movie with Tony Stark, he really is totally having a catastrophic mindset from recovery from the whole New York incident in the Avengers. And I love that they put a kid in that movie as almost his psychologist. To me, that was phenomenal. Like that was top-notch writing there for me. Because literally, for you, that you haven't seen this, Bianca, I'm sorry that you didn't see this, but literally he gets totally scared about everything. Kids basically like, what are you scared about? Are you having a panic attack? Well, then just fix it. Yeah. Are you having an anxiety attack, Tony, right? And in the end, that's one of the things, like just from a child's perspective, he says, well, you consider yourself a mechanic. Why don't you build something and fix it? And you just sit there going, this kid gets it. Like kids in that way, you know, but they can take on these events too. They can catastrophize stuff as well. But it's just kind of wild that they kind of use that process in there. It was actually really good to me, for me to kind of see that kind of stuff. But yeah, cognitive distortion's there. Some of you may have a little bit of cognitive distortion when you're getting ready to go in your clinicals, that you're worried that everything's going to go to crap on your clinicals. That, oh my God, what if I screw up? Not realizing that part of clinicals is screwing up. Like, I'm sure that if we ask most of you guys at some point during your clinicals, yeah, first day at an LTAC, right? My first day at an LTAC working in the coma unit, I was just like, what happens if I pull out a ventilator or something? Like, that was totally terrifying me. So many tubes, right? I'm going to pull everything out. And then first time the nurse came in, she's like, well, you can pull this one off. And she just started yanking stuff off. And I'm like, oh, okay. Well, I guess it's not that bad then. You know, the feeding tube gets throwing food all over the place. But yeah, I mean, even coming into school for some of you guys, you probably had a little bit of anxiety towards it. I know I did. I know going back to school after being in the IT field for so long, and going into PT, I was a little terrified. And especially when I had my first day of class and my entire class was 21 and under. Like my entire class of 20 students was 21 and under. And there I sat, you know, I'm just going to say north of 30. I was like the old man of the group. I scared of the MPTE, right? Good. Oh God, it's going to be horrible. I'm going to fail. Unfortunately, when we do stuff like that, then get that cognitive distortion, that can really affect actually if you pass or if you fail. And I'm actually going to use this as an example because we just had a student that just advised us that he passed the boards on his third try. So he emailed us today. He's like, I just want to let you guys know, thank you. I passed on my third try. God, that was painful. I haven't found out about that yet. We don't know. I think she just took it this week, so I don't know yet. But he took it like the second day, he took it January 2nd, so he got his results already. But yeah, so what was interesting was he actually ended up going to a test anxiety psychologist. And when I was talking to him, he says, one of the things I found out was the reason why I wasn't doing well wasn't because I didn't know the content. It was because I was going in with the mindset that I was going to fail. He goes, and that made me sit there and second guess every single question I was doing. And I remember on his first test, he didn't finish 25 questions because he ran out of time. because he was second guessing everything. So he needed a little bit of help, and he reached out and he got some help and he passed. And now he's a PTA. Huzzah. And that helps me, and that makes me very happy because I needed some good news today. I'm just saying, with all this COVID stuff, I needed some good news. So let's look at pain as a society. What happened when we made pain the fifth vital sign? Because that happened in like the late 80s, early 90s. What happened when we made that a vital sign? What does that kind of do? Do you think that could affect things? Right? The main thing it affected was it's caused us to think pain is bad. We should not be in pain. If you're in pain, you are broken. Right? It also caused some docs to take on this mindset that all pain must be gone before doing normal ADLs, IADLs, and even movement. Yeah, we developed more drugs. And honestly, the pain as a fifth vital sign came from Purdue. Not Purdue, the school, but Purdue Pharmaceuticals. They had developed all kinds of little charts that are like, pain is the fifth vital sign. Make sure you get your pain from your patient. At the bottom, be sure to prescribe oxycodone. Right? So we started thinking as passive treatment is the way to go. Pain pills solve it all. Right? No matter what you do, if you don't get rid of your pain, it will get worse. And then working and living a normal life will increase your pain. So, you need to escape from your pain. We've got it over here. Right? Let's look at Purdue real quick because I throw this in here just as a thought process. Right? So Purdue's Pharmaceuticals in the early 90s, Purdue Pharmaceuticals heavily marketed opiate-based pain relievers, which previously only used to treat chronic long-term cancer pain. They prevented, and I put it in quotes there, research to physicians showing how opioids were no more addictive than someone taking Tylenol or aspirin. So when they presented that research, all of a sudden non-cancer pain increases. In 1997, they had 670,000 prescriptions. In 2002, so that's 5 years later, that's 6.2 million prescriptions, right? 2012, 259 million prescriptions. Yeah, Dopesick does cover this. And honestly, Bianca, if you like the show, read the book. Please read the book. That author really deserves picking up the book and reading it. I bought both a physical and a digital copy because I loaned the physical copy out quite a bit. So cancer pain, on the other hand, only went up by a factor of 4. So, if there were, 600,000, it didn't go up as much. Interestingly enough, the final number right now equates almost to every American to have a bottle of pain pills, including kids. Think about that for a second. There's enough pain meds on the market right now that are prescribed, not just sitting in a pharmacy somewhere, that every one of you can have a 30-pill bottle of pain meds, including your kids. So Jason's daughter can have some pain meds. He can have some pain meds. Bianca can have some pain meds. All of us gets pain meds. It's like Oprah. Everyone gets pain meds. Reach under your seat. You'll find a bottle of oxycodone. So Purdue stated that the addiction rate for even moderate use of heavy opioids in non-cancer pain was less than 1%. Recent studies have indicated the risk of addiction could be as high as 50% from one pill. Think about that for a second. You take one pain pill, and you may be in that 50% that you could get addicted to them. Right? That's kind of scary. In 2007, they were charged in federal court by a young district attorney by the name of James Comey. Have we heard his name before, ever? Any of you heard of James Comey before? Yeah, he was head of the FBI for a short period of time before, He's also a really, really big man, by the way. Like, not size-wise. He's like 6'7". I've seen him do speeches when I was back on the East Coast, and it's just a giant. They charged Purdue along with 3 company executives. They pled guilty to criminal charges of misbranding opioids and were ordered to pay the fines of about $634 million for the entire period from 1996 to 2006. In 1996, their gross sales were $44 million. 2001 to 2002, it ballooned to $3 billion. So that's $634 million, drop in the bucket. But this is how we treated pain. Rather than treat it, we medicated it, right? Ironically enough, if you look into the history of pain meds, and that's actually covered in the book itself, which is kind of interesting. The author does a really good job of this. And some of this does come from that book. We made the same mistake right after the Civil War. So after the Civil War, we created opium and poppy dens because we had so many soldiers that were returning from the Civil War that had chronic injuries, amputations, blah, blah, blah. And if you haven't ever gone to a Civil War battlefield and seen what the hospitals on Civil War battlefields looked like, it really is it's not a hospital. It's a butcher shop. Because we didn't have all the sophisticated stuff that we have nowadays to save soldiers. But interestingly enough, back then they said, well, we can solve your pain with opium. And so then the federal government realized, oh crap, we've got all these people addicted to opium. We need to stop it. We need to make it illegal. So pharmacy companies said, but we're making money. And they said, okay, we'll stop selling opium. Does anyone know what they released next in the early 1900s? Instead of opium, they came up with a new medicine. The new medicine they came up with is heroin. And they said, not addictive, don't worry about it, treat your pain. And then what happened after World War I and World War II? We had a bunch of people addicted to heroin and also meth, but that's beside the point. Yeah, Riley's like, oof. This is also why people have distrust. You're exactly right, John, right? But yeah, I can go into the meth thing totally on its own, but I'm not going to go into the meth thing on its own because we did give our soldiers meth, by the way, in World War II. The Germans were doing it, so it was okay that we did it. So these soldiers came home and they were given heroin to treat their pain. And then we went, oh, we got a lot of addicts. We got to stop giving opium. Or we got to stop giving heroin. And so the pharmaceutical company said, you know what? You're right. Sorry, we should not have done heroin. Here's oxycodone. Yep, they gave the kamikaze pilots meth. Yep. It's interesting. I love war history. It makes me. I don't know. I'm a complete nerd. And evidently, for those of you guys that are younger, like the Trumans and the Johns and the Anthonys, once you get to my age, it'll be interesting to see if you get interested in history because evidently it's a thing. I didn't realize that was a thing. One of my older friends or one of my older patients told me. It's like, yeah, it was about your age that I started really getting interested in history. I guess it's a guy thing. Part of the midlife crisis, I guess. But yeah, so we went opium to heroin to modern day pain meds. I'm calling you guys young. I'm saying once you get to my age. Yeah, soon to be old. I'm soon to be ancient. Right? One interesting thing here that's kind of interesting about this $634,000 or $634 million. Does anyone know how much so the 3 company executives were all family. They were the Sacklers, is the company that owns Purdue or owned Purdue. Does anyone know how much they actually paid that $634 million in fines? Anyone want to hazard a guess? 0. Yeah. Because what they did is they said, well, we sold our interest in the company. We are now just on the board of advisors. We have nothing to do with for Purdue Pharmaceuticals. So you can't charge us. And they took the charges to courts where they knew that they would get preferential treatment. For example, they were charged in Virginia and West Virginia. They took the course back up to New York where they were home based and got a lot of these charges reversed. It's kind of sad. I've got a whole I've got a whole video on the Sacklers, which is interesting. So we need to look at pain differently is what I'm saying. Why not look at pain from a perspective of traffic light? Right? So understand what to watch for. Green light means keep going. Yellow light means to monitor. Red light means what you're doing isn't working and you need to change your approach. So let's look at pain like that, right? So what would we consider a green light or a green flag indicating treatment approach is working? Well, pain may be improving. Or pain may not necessarily improve yet, but function is improving. Their social cognitive function is improving. They're not focusing as much on the pain, right? And the more focus is now on the after the pain. They're getting better. Their mood is improving. They're not complaining as much. Yeah, centralization is occurring. Right? All of that is signs that what we're doing is working. Right? And that's the stuff we kind of want. So what are some yellow lights? Well, increased fear of pain. We start seeing patients going into a depression, increased irritability or stress, right? Those are some yellow flags. We got to pay attention to those, right? We start seeing patients with extended bed rest or bed rest, no compliance or poor compliance with their therapy. You know, they're coming in, you ask them on a scale of 0 to 10, and they're like 10, right? They start relying on all forms of pain assistance, sleep changes, disturbances, lack of. I mean, I'm sure you guys can tell I'm starting to get some bags under my eyes from not sleeping well. Medication with alcohol or recreational drugs. Increase of smoking or starting smoking is a big red, is kind of a yellow flag. Let me add one caveat to here, because I know this is a hot topic here, especially in Nevada. When we talk recreational drugs, one of the ones we add to that is Mary Jane, right? Marijuana. Can marijuana help with pain?
Yes, especially CBD.
Yeah, right, good. So there's the key thing, and you stressed it really well, right? Marijuana by itself, maybe not because of the THC in it, right? But the CBD has been shown to really improve some pain. But again, it's just like everything else. Because whether we like it or not, there is an addictive quality to marijuana. It's not as addictive as, say, heroin and cocaine, right? Or even pain meds. But there's still that addictive quality. And especially when you get those people that are those addictive people, it can affect things. The other bonus to this is, and again, I'm just using this as from treating patients that have used marijuana, is the CBD helps them with pain, the marijuana helps them with appetite and rest. So there are some bonuses to it as well. So I don't fully believe there is no medical value to marijuana. I believe there is some medical value. I still don't 100% believe that we should be using it in the physical therapy world because the research still is not 100% there yet. But I think there's some benefit to it. And I've seen some people where, you know, I've seen a lot of vets that have gotten off of heavy pain med usage by using marijuana. There are other drugs that are out there as well that can help with pain meds or other herbal substances. One of the ones I think of is Mitragynous speciosa, which is kratom. There's some studies that are starting to show that because that works on the brain a lot like an opiate, but isn't an opiate, that's showing some positive signs in pain relief. And I'm not, please don't think at any point here I am advertising go start smoking weed. That's not what I'm saying. Although, did anyone see the recent research about COVID and marijuana? Has anyone seen that? I'll have to find the article if you haven't seen it yet. There's actually research that one of the cannabinoids of COVID strips off the spike proteins. And then stops the COVID from replicating. So, I mean, now more research has to be done. This is just a single study so far, right? But I didn't have marijuana curing COVID on my bingo card. I'm just saying. That was not on my bingo card anywhere. And it's interesting enough, part of the study showed that the people that are long-term marijuana users are less likely to get COVID. They actually kind of have some research into that. So I guess eventually the only people going to be left from COVID are stoners is what I'm saying. I'm joking. I'm kidding. I'm kidding. But there are all kinds of drugs that are out there. Like I said, you've got marijuana, you've got kratom. There are some other Middle Eastern, like Eastern medicine type concoctions that help. I remember back when I was Vicks, I put Vicks on everything. Vicks and Tussin solve everything, John. Vicks and Tussin. That was my mom's solution to it. Vicks and Tussin solves everything. Oh, especially, and the only reason aloe vera. The only reason I also kind of joke about Vicks and Tussin is because, again, I have 3 godchildren that are Filipino, and their grandmother is like, Vicks and just put Tussin, Vicks, or Wicks. I'm sorry, Wicks on everything, Wicks. And literally, like, I remember one day when I came over and they all had like the flu, the house just reeked of Vicks. It was great. It was hilarious. But yeah, so it's just kind of funny. But there are some other drugs out there, and like I said, when I was on the East Coast, we had a little Eastern medicine doc that was near one of my clinics, and he had some interesting. Is the brown thing in general? Okay, just saying. One of the things that is funny, and just as a funny aside to it, one of the things he had in his shop for pain relief, and this is kind of funny, I'm not even joking, was powdered deer penis. How many of you want to take that for your pain meds? Literally dehydrated deer penis that they grind up and make into powder. It was just kind of funny. Yeah. And it was funny. It's like, my people swear by it. All the people at patients he's had, and I'm like, okay, I'm pretty experimental on stuff like that, but I think I'll leave the deer penis to other people. I'm just saying. All right, other family flags that might come with yellow flags: overprotectiveness or underprotectiveness of the family. Punitive responses: patient gets worse and they get kind of irritated with you, or the family starts dissociating, or they start dissociating. Work yellow flags: if they're doing manual work, that can be a yellow flag to pain, because manual work tends to lend us towards more pain. Looking at their past work history, changes rapidly in work history. Belief that work, especially manual work, is bad for them. If they're unhappy at work, low educational background also can be a red flag. Shift workers, or in this point, we now have a new term, because shift workers was my kind of term when I was growing up. Does anyone know what the new term for? We don't call it shift work anymore. What's the new economy that we have? Has anyone heard this before? We've got the gig economy. Does anyone know what the gig economy means?
Like performers, musicians, and artists, and
yeah, that's where it started. You're exactly right. But now it's also including like Uber drivers, what are the food companies, DoorDash, all that. That no one's working a traditional, not many people are working a traditional job. And actually, I know what's kind of scary to me is I know a lot of teachers that supplement their teaching income by doing stuff like that because they're not making as much as teachers. But yeah, so any negative work experience was the pain. Compensation flags: lack of financial incentive to return to work, make more money while not currently employed. That can happen. It's a pretty rarity. That's my life as a professional dancer. Exactly, it is, Riley. And even like somebody like a massage therapist is very much like that. Because a lot of times if you're a massage therapist, you're not an employee, you get paid it. So like, at least in the time that I was doing it, I got paid if I had patients. If I had no patients, I was there at the clinic and I didn't get paid. And I always felt bad asking for tips because I don't know, I'm weird. I don't like giving tips. does that make me weird? I really don't like tipping people. Does anyone else feel like that? Just curious, or am I just a weirdo? Okay, some of you, because to me, if I'm tipping you, it's telling me that your company's not paying you enough. Or if I'm forced to tip you. Right? If I want to tip somebody, I will. You know, if I feel like you deserve a tip, I'll tip you. But in a lot of countries, tipping is actually considered rude. Especially in like Japan and stuff like that. I was never able to get tips when I worked. It's funny, I usually hear the opposite, Brooke, is usually the people that work like that tend to tip a little bit more, but I don't know. I'm just weird like that. I just get kind of weirded out tipping people. Sorry, it's just side effect there. And contrary to popular belief that you'll see on the news, specifically certain news channels, people do not get paid more on unemployment. How many of you guys have ever been on unemployment? Just curious. Have any of you actually been on it long enough? Did you make more in where you were working or on unemployment? Because I always made more where I was working. I never made more on unemployment. Like even with the incentive, and it was funny when we gave that incentive over COVID, that was like an extra $600 a month. If you looked at that on average, if you made the maximum unemployment, you were getting like $25,000 a year. I'm just sitting there going, why are we upset that people are making under 30,000? I don't know. It's just kind of my thought process. I'm also not one of those people that I'm afraid of somebody making $15 an hour, just to let you guys know, because I would rather more people making money, more money going in the economy, because eventually that means more people will come into physical therapy, which means eventually more money for me anyway. I'm okay with that. Extended time off of work due to previous lack of time off work, history of repeated workers' comp pain, previous history of similar conditions. And I guarantee you guys, if you ever experience a workers' comp claim yourself, so you injure yourself as a physical therapist assistant, they will look into all your previous workers' comp claims. It's just, that's the nature of workers' comp. Don't think it's personal, it's just the nature of workers' comp. Just have an answer for it. Talk of consistent legal action. I loved that when I was in the clinic. Do you think I should sue? Maybe I should sue. Do you think I should sue? Do you think I could get some money out of this? I think that's our society a bit. Just as an aside, and this is not to sell it, make sure you guys get indemnity insurance when you get licensed. I carry indemnity insurance just because it's safer. Can you give me more time off work? I'm not quite ready to return yet. I love that. Or talking in the clinic repeatedly to other patients to validate their reasons for experiencing pain. I love this with old folks. And I'm starting to get there actually. When you have like 3 old folk on 3 mats beside each other, and they're like, oh yeah, I remember when I had my total knee replaced. God, it was so sucky. And they're like, yeah, I just had my hip replaced. And they start commiserating about their pains. Did anyone see that in the clinic? It's so hilarious to me. I don't know why it's funny. Like, I think it's just a social construct of people getting older, but it's just funny when I see that. Misery loves company. Exactly, Joe. Medical diagnosis, yellow flags. Looking for medical sanctioning of the disability. Seeing multiple diagnosis and possible diagnosis that would conflict with each other. My case is special. My low back pain is different than everyone else's low back pain because it's my low back pain. They want passive treatments. Sure, somebody encountered this. Don't have time for therapy today, but I'm here to get my traction. I mean, I just need the E-stim today. Just give me my E-stim, my ultrasound, and I gotta go. Did anyone have that happen? Yep. Yeah, or I don't have time for therapy, but can you put me on a hot pack? Right? And you have to explain to them that's not the way therapy works. Repeated mention of lack of fixes from previous providers. How many visits do you think I could get for this condition, right? Well, this hurts, so I should avoid it, right? No, not necessarily. So those are our yellow flags. Then our red flags. So what would be some red flags we might consider to, or maybe just talk to the PT? The patient's pain increases drastically, but proportionate to their condition. So meaning they have low back pain and their pain goes from a 6 to a 9. That's still proportionate to their condition, but we still want to make sure we cover that with the PT. Patient's pain migrates down a predictable pattern like a dermatome or a myotome. Continually getting worse from the social societal world, meaning they're starting to withdraw, right? Patients begin discussing what would happen if you got litigation against you. Oh, I love these. Does your clinic have malpractice insurance? Do you have malpractice insurance? Did anyone hear that ever? Just curious. I've had patients that ask me that outright. Just curious, do you have malpractice insurance? What? That's a red flag. You let your PT know. If you hear that, please let your PT in front office know. Because all that is a lawsuit waiting to happen. How does one go about filing a complaint with your state boards regarding clinicians? I've had this before. I saw ABC therapy and I was seeing Bob over there, and Bob sucks. How do I file a complaint against him? How would you guys handle that question? What would you guys say? I'm just curious. There's no right or wrong answer here, but what would you guys say? Google it, okay? Yeah, that might be that's actually not a bad answer, Joe. I didn't think about that really. Yeah, my usual answer to that is I really don't know because I've never had any claims filed against me. So I'm not really sure. You'd have to look that up. Not sure. I don't tell them to go, oh, we're all licensed by the PT board, so that's where you could go file a complaint. Even if I know that Bob deserves the complaint 100%, I'm not going to throw another clinician under the bus just because a patient wants to throw them under the bus. Unless, you cross me. And then, Joe, you're out. Watch it. I'm watching you, Joe. I'm watching it. No, just kidding. Any other red flags that you'd worry about stopping treatment and getting a PT that's not covered here? Anything you guys could think of? Anything not covered here? Maybe increased hospitalization usage, where they're constantly going to the ER for their pain. Right? We can't do that nowadays because there's like no room in the ED. And a lot of EDs send you away lately with pain. I just noticed, I was reading an article today that showed that elective surgeries, so those would be the joint replacements, spinal surgery, stuff like that, and organ transplant surgeries are down 60% because they don't have enough room for those patients right now. It's kind of scary. I don't know. So pain is a malfunction of the cognitive process. The patient suffers a painful experience because he's afraid of the painful experience, poorly understands it, worries about further damage, suffers another painful experience, and they get stuck in that cycle, right? So for us, we got to go through a modern thought of pain. We need to simplify it down. Pain is a multiple system output activated by the brain due to a perceived threat, whether that threat is real or not. So that really shows that pain is not in the back, in the arm, in the shoulder, in the hip. The pain is here, right? The pain is in our brain. Epidemiologic data shows that chronic, widespread, non-specific musculoskeletal pain is on the rise, especially in low back pain. Some studies show that chronic pain prevalence may be as high as 35% of all patients visiting a healthcare provider. That's a lot of people. So 35 out of 100 people have chronic pain. Americans account for only 5% of the world's population, but consume 80% of the global opioid supply and 99% of the hydrocodone supply. Yeah, Chris, I'm glad Chris it struck you as well. Like, that amazes me. Right? I don't know why that fact there just completely and utterly blows my mind. So that means as a PTA and as a PT, we have to treat the brain as well as the body. But I'm a therapist, not a psychologist, Mr. McKeever. Well, I got some news for you, kiddos. You may not be licensed as a psychologist, but I'm going to do a little psychology with some of these patients, right? So how have we thought about it in PT? The main reason of pain is a stiff joint. It's tight muscle. It's altered incorrect muscle recruitment. It's trauma. It's wounds, right? We used to think that those are what caused the pain. But in reality, right, those are a little bit of flawed views because all they triggered was the pain response. They didn't trigger the pain itself. They triggered the response to pain. So we kind of have to kind of pay attention to that when we're talking about it. But what if the disability is due to a faulty brain? So now let's talk about, here's our patient again, she's back. Hi, my name is Edith. My pain is due to my chronic bulging discs at L3, L4, L5, L6, and L7. I have bulging discs because I have arthritis and degenerative joint disease, which has caused me to get degenerative disc disease. Now I think I might have fibromyalgia stuff or maybe lupus. I mean, I had a weird rash on my face the past couple of weeks when I wake up. My pain meds aren't working any longer, and I only take them when I need them. But are there stronger meds I could get for them? I read I shouldn't do any exercise until all my pain is gone because pain is the body telling you to stop until you don't have it anymore. Maybe I have this rare blood disorder. Does this sound like a patient? Or does it sound like any of your patients? Yeah, it does, doesn't it? I love the L7. Right, L6 and L7. Anyone catch that? Was anyone thinking, wait a minute? No one? And the only reason, too many L's, yeah. She's taking too many L's, Anthony's with the problem, right? Anyone have a family member like this? Just curious. So I'm going to be a little bit honest about this. Used to, right? I'm going to be a little bit honest. My wife who passed away was a little bit like this. A little bit. Friends, okay. And it wasn't her, I mean, yeah, it was her fault a little bit, but it wasn't her fault because of her disorder that she had kind of made her start taking on, and understand my wife that passed away was a nurse. So she was already a healthcare provider. And I tend to find, I don't know about you guys if you saw this or not, but I tend to find that healthcare providers are the worst patients. PTs and PTAs especially. Yeah, Brooke's like, yep. We have a tendency to overcritical of our self-diagnosis. We also have a tendency to be overcritical of the therapist we're seeing and stubborn, right? But I mean, this lady comes in and she just shotguns this all out at you, right? So what do you do? What do you do? This patient comes to you and just literally spews this verbal diarrhea at you. You look at her and go, okay, Karen, you got to figure out what you can fix, right? Let's take this down to one or two things at a time. First of all, you don't have 7 L sections, right? So we've got to kind of think about this. So there's a little bit of flaw in our education. We approach all diagnoses on prevailing biomedical models, focusing on tissue and injury, right? Orthopedic-based professions commonly use anatomy, physiology, and pathophysiology to explain to the patient, right? So any of you ever see this in the clinic? Your PT's there and they've got the model of the spine or the knee, and they're like, so if you look at this little model of the knee here, these brown structures are your ligaments. The white material is your meniscus. The red beefy material, that's your muscle. You have a microscopic tear, we think, of your meniscus right here, which is impinging upon and not allowing your knee to move freely through its full range of motion. The piece is catching. Did anyone ever see something like that on an eval, or even maybe you've done it? Right? I mean, we teach it that way, right? Yeah. And at what point does the patient kind of zone out? Like, so if you look here, yeah, the beginning, they're just like, oh, great. Yeah, they're looking at the model and going, but what about me? I don't care about the model. What about me? Right? Studies have shown that there's limited efficacy in decreasing pain or disability by looking at a model. But we have models all over the clinic. Now, some patients do legitimately want to know. I'm not saying all models are bad, right? Studies have indicated that purely biomechanical approaches may increase patients' fear. So if we show them that model, like I show them a model of brain and say, you know, back here is your visual cortex on the back of your brain, and that's where you got hit. It could actually increase their avoidance of injuring that area again, which may be a good thing, but it also could be a bad thing, right? Just think of all the literature in your clinic that's kind of hanging around the walls, right? Unless you've got one of those clinics with the cat on the edge of the thing that's like hang in there. Most of it is anatomical in nature, right? It's the typical stuff we have hanging up around the school as well, right? This is an interesting study. One study indicated that almost half the people with the bulging shift discs displayed no sign or symptoms of low back pain. The disc that may absorb some shifted weight. So literally, and there's a lot of studies out there that show all of us probably have a shifted or bulging disc somewhere in our back, and we probably don't even know it, right? Because it's not enough to trigger something. It's not enough to bother us, right? But then maybe you go in because you're having a abdominal CT because you're looking to see if you have a bowel blockage. You get that abdominal CT, and the doc comes to you and says, oh, by the way, Brooke, you know, while we were doing the abdominal CT, we noticed that at L2, L3, you have a really bad bulging disc on the right side. What happens? Now, you didn't have any pain before, but now I've told you you have a bulging disc. I think of the pain, right? Yeah, now maybe could you start getting back pain from that? Yeah, right? Because now you're like, oh my God, I have a bulging disc? Well, how did I get a bulging? I've been going to yoga for years. How did I get a bulging disc? Right? And you're like, there's just no way. And then you're like, oh, wait, you know, that other night when I rolled over in bed, man, I just had that. Yeah, your brain knows I had that tweak. Could that have been a nerve impingement? And all of a sudden start cascading down that effect. So this is interesting. A study done by Tate, Levy, and Noel and Associated, right? So this is interesting. Patient underwent a microdiscectomy where they were shown their bad material after surgery. Recovered significantly better than who were not shown their bad material. Why do you think that is? So the doctor took out a jar and it's like, so here's that meniscus part that I told you was bad and I pulled it out. So their leg pain got better, 91% versus 80% without showing it, 86% in back pain, limb weakness improved. So look at that though. Limb weakness improved by 90% versus 56. Is that crazy? Like, to me, that's nuts. And reduced back pain medication from 92 to 69%. Here's that part of the disc I pulled out. Yeah, because they believe the pain, that disc was the pain, right? But I don't know, to me, that's crazy. It just blows my mind that's showing that. And it's funny because I thought about that. And guess what one of the docs did to me, or my surgeon, when he did my anterior disc surgery? He showed me the pieces of material that he took out of my disc or out of my spine. And then after I started reading the study, I'm like, okay, was he trying to mess with me here a little bit? And, you know, that was an interesting thought. So this is interesting. Over time, right, we start developing arthritis. It starts about in our late 20s to early 30s. Believe it or not, the worst arthritis pain, or worst arthritis problem peaks somewhere around here, right? So developmental low back pain. That's where we start developing it. But arthritis really peaks way out here in the 70s. So it's not arthritis necessarily causing us our low back pain. Well, what is it? Well, it's probably a lot of what we do, right? So let's look at rotator cuff injuries real quick, because that'll probably be a good time to then take a break after this one. 1/3 of the people over 30 have an abnormal finding on their MRI. Work does it too, you're right, Joe, right? 2/3 of people over 70 have an abnormal finding on an MRI of rotator cuffs. But 60% of the people reporting rotator cuff pain are under 45. Interesting enough, of those people that have a successful rotator cuff repair, 90% of those people still have further abnormal findings. And we've actually shown now that as far as rotator cuff tears go, physical therapy may be far more beneficial than rotator cuff tears versus surgery. Does that benefit us? That studies have shown PT is better? Yeah, right? Does it also benefit the patient, though? What benefit does that provide for the patient? So if it shows that, yeah, no surgery, saves money time, right? Maybe misses out on missing work because of the surgery, risk of infection. I've seen the same similar studies for meniscus tears in the knee. Is that patients that get meniscus tears that end up going in for surgery, I've, at least personally, and this is subjectively, so please don't think this is Mr. McKeever saying everyone, but I've seen people that usually go in for either rotator cuff repairs or meniscectomies come out worse than when they went in. The other way I've seen it is carpal tunnel surgery. I've seen a lot of patients that go in for carpal tunnel surgery that come out worse than when they went in for carpal tunnel, when they went in with carpal tunnel pain, when they could go see a wonderful hand therapist. Speaking of which, I just got told, say hi back to all the students, tell them to get into hand therapy. There. We're always looking for hand therapist PTAs. All right, so let's look at this situation here. You're walking down the street, singing do-wah-diddy-diddy-dum-diddy-do. You miss the edge of a curb, and your right foot slips off the curb. You completely invert your foot to the point of a complete stretch of the lateral compartment, so you get a sprain. You get an initial shock of pain, mainly from seeing it happen. As you're kind of hanging off the curb, you notice a guy coming careening at you in his Mustang, not paying attention at like 50 miles per hour. So this guy's coming barreling at you at 50 miles an hour. You're hanging off the curb. What do? Move. Yeah, you like bounce back, you jump back, you drop back. Where'd your pain go? Your pain went to the hip because you fell, right? But it went away. Think about that for a second. Did you think about your ankle at that given moment? Probably not. Because pain is a decision of the brain, right? Fight or flight, sympathetic kicked in. But pain is that decision of the brain based upon its perception of a threat. When you stepped off the curb and twisted your ankle, the perception of the threat was that ankle twist. But when you saw that car, that ankle twist wasn't as bad as it was. Right? You're like, oh crap, yeah, my ankle sucks. Brain, like in milliseconds. Yes, that ankle injury hurts, but if I don't get out of the way of the car, there's a potential I could die. You get out of the way. All right? It's kind of crazy when you think about that. And it just makes you think going, okay, how does the brain do this kind of stuff? Because the brain overrode your pain response at that given moment. And this goes back to like war and stuff like that with soldiers, because there have been plenty of soldiers that fight through getting shot, having limbs blown off, and they're still in the fight because their perception of threat is not necessarily, oh my God, I just lost a leg. Their perception of thought is the enemy is still coming. It doesn't matter if I have a leg or not right now because I'm going to die. So that sympathetic system has an amazing effect on your body, right? So that literally means pain is in the brain, plain and simple. So it is 31 after. Let's stop sharing here. Let's pause record. All right. So last we left, I finished with pain is in the brain, plain and simple. Pain is a multi-system output activated by individual specific pain neural signatures. What that means is that pain itself, what's confusing there, Diana? The judgment? That's what you're talking about? Oh yeah, it is. Well, I can talk more about that later, but we'll stick with this for now. If I have time, I'll give my kind of research on that. So that literally means pain is a learned experience. So when the brain perceives a threat, that means a neural signal is activated. But what if that pain doesn't really exist? Have any of you treated anyone with RSD, reflex sympathetic dystrophy? Did anyone see any patients with that? Where they've got pain in a limb or something like that, but there's no injury there. It's pretty common for patients to get stuff like that, right? Complex regional pain syndrome, right? CRPS. So how dangerous is a threat? That's what happens when the brain starts receiving a threat. If the threat is dangerous, it needs more information, and then it gets the initiation of the pain response. If the threat is not dangerous, yeah, and hopefully, Riley, you do get to see it's kind of an interesting. It's both a sad and interesting treatment to see with CRPS, right? Because you learn a lot from it, and some of this comes into play with that, right? But it also is kind of sad for the patient. If the threat's not dangerous, you should have an inhibition of the pain response. So is this lecture painful yet? Right? I'm sure for some of you it is, right? But we've realized that pain is a lot more complex than we once thought. We used to think pain equals injury, injury equals pain. But then how do we have pain without injuries, right? I'm going to use a great example of it. Heartbreak. Have any of you ever experienced that? Just, you don't have to say if you don't want to, but where somebody's broken up with you and it's really hurt. That's not an injury. So how do we have, and that can trigger pain. So how does that trigger physical pain if there's no injury? Or maybe you've lost a loved one and you feel intense pain from it. Right? Losing it all. Okay, there we go. Losing a pet. And it's so devastating. And the pain that you get from that can be more crippling than having a spinal cord injury, which is just insane. And not insane I'm not saying in a bad way, but just one of those you're like, okay, so that means my brain is in pain, right? So actually right now for you guys, your brain might be in pain. You think this lecture is a perceived threat. But that tells us that we don't necessarily have to have problems to have pain. Interesting. So with PNE, or pain neuroscience education, which is kind of a new up and coming field in physical therapy, we're looking at research that shows explaining to patients their pain experience from a biological, physiological, and psychological perspective allows a patient to move better, think better, exercise better, and think differently about their pain enough to push through it. So that means spending time one-on-one with your patient on something other than pure physical therapy and on education can go a long way to improving their pain. So what kind of adjunctive therapy can we add with PNE? Well, manual therapy, right, including mobilizations and manipulations, soft tissue treatment, neural tissue mobilization, where we actually mobilize the nerves, spinal stabilization, HEPs, circuit training, right? We can even do no adjunctive therapy to pain neuroscience education and just provide the patient with pain neuroscience education, where we sit and talk about pain. And there's actually been a couple studies that show that, and it's in and of itself, just spending time explaining pain to a patient explaining what's going on, why the brain is acting the way it's acting, has been shown to improve pain and function. It's kind of crazy. Right, and that's what we're going to talk about in a little bit, Riley, actually, is then what do we do about billing? Right, so hold that thought for just a few. That's a good thought, though. So what should be in P&E content? Neurophysiology of pain, talking about how the brain works, right? Maybe stop referencing purely biomechanical and anatomical models. We avoid that kind of emotional and behavioral aspect of pain, right? We talk about nociceptive and nociceptive pathways. We maybe talk about the basics of the neuronal pathways, including fiber types. Do you remember all those fiber types? A beta, A delta, C fibers. Do you remember a little bit about those? Did you guys talk about that in, I think, modalities, right? Talk about neurobodies, dendrites, the action potentials, depolarization, hyperpolarization. Talk about inhibition models. And we also have to talk about the plasticity of the nervous system. Because just like pain is a learned behavior, if it's a learned behavior, that means our brain is plastic enough to unlearn that behavior. Right? Because anything that's learned, we can unlearn. It may be hard, especially if it's become a habit, but we can unlearn it too. So peripheral sensitization. These two terms I put in here because these are becoming more and more questions on your boards about this. This idea of either peripheral sensitization or central sensitization. Have any of you guys talk about this either in the clinic or maybe in your studies? Or just seen the terms? No? Okay. Well, let's talk about it for a second. So peripheral sensitization is an increased sensitivity to an afferent nervous stimuli. This occurs after there's been an injury or cell damage to an area and produces a flare response due to nociceptive producing a lot of neuropeptides and substance P, which results in increased heat, touch stimulus, which is a primary hyperalgesia, or hyperallodynia, which is increased pain. If the stimulus was not painful prior to the injury, for example, a gentle stroke to the skin, which before the injury is not painful, is now after the injury interpreted as pain. So that's saying that you can get pain from a non-painful stimulus because you had a previous pain and your body reacted negatively to that pain. That is kind of the idea of peripheral sensitization. That is complex regional pain syndrome in kind of a nutshell, right? Where the patient has pain despite the fact that there's not a physiological reason for it. Central sensitization is nociception is described as the neural process of encoding of noxious stimuli. Central sensitization is defined as the increase in responsiveness of the nociceptors in the central nervous system, either due to normal or subthreshold afferent input, resulting in hypersensitivity to stimuli, responsiveness to non-noxious stimuli, and an increased pain response evoked by stimulus outside of the area. So the main concept here I want to kind of talk about, because there's been a lot of like research and a lot of new kind of studies into this peripheral and central sensitization idea. Peripheral sensitization is basically saying that nerves on the periphery are hypersensitive to stimuli, and so therefore they're going to react inappropriately and may react with pain. Central sensitization is the central nervous system at that point has become so overloaded and kind of hit with different sensations coming in, specifically nociception or pain sensation, that they now respond to everything with an almost pain-like response. So one is a peripheral problem, one is a central problem. Which one of those do you think is going to be harder to overcome?
Central?
Yeah, almost every time that we talk about central nervous system issues, they're the hardest to overcome. And there are some studies right now that are showing that incontinence, where a patient has incontinence, and I'm not talking like because they can't move, but actually just that incontinence that occurs just randomly because of whatever the reason might be, that incontinence may be actually a central sensitization issue. That, you know, the central nervous system is no longer reacting properly to the normal bladder filling and emptying process. So that even if the bladder is filled, a small amount, the body detects that, the central nervous system says, oh my God, I've got to empty the bladder and I've got to empty it now. And so they have urinary output when they shouldn't have urinary output, or fecal output when they shouldn't have fecal output. And that's an interesting process, because we've always thought that a lot of the problem with urinary incontinence is strengthening of the bladder or strengthening of the pelvic floor, which it is. Some of it is. But, we've had patients where we've exercised their pelvic floor, we got their pelvic floor strong, and then they still end up having this issue with urinary incontinence. And then we're like, well, why is this still occurring? And then we're starting to realize that maybe it's not a bladder issue, it's a brain and spinal cord issue. Yep, John?
Yeah, wouldn't that make like the peripheral sensitization a little more difficult to treat, since we don't know where it's coming from?
It could, but with peripheral sensitization, at least we can accommodate. It's almost like when we talked about vestibular issues, right? So when we have ear issues in the inner ear, we can treat that. We can, it may be hard to treat, but we can work on that. When it gets to the brain and spinal cord, we can't get in and touch and manipulate the brain and spinal cord. Does that make sense?
Okay, that makes sense. Perfect.
So like, let's say that I have complex regional pain syndrome on my arm. That would be a peripheral sensitization issue. What kind of stuff can I do to lessen the sensation of pain when people touch me?
Desensitization?
Yeah, so I'm going to do exposure therapy, right? That's really what it is. I mean, you think about desensitization, I'm going to do exposure therapy. I'm going to start with some nice soft stuff, right? I don't have any cotton or anything here to demonstrate, but yeah, I'm going to start with something nice and soft, right? And work on that and reducing the pain signal from that. And then I'm going to slowly get more aggressive with that pain desensitization. But now comes the question, could central sensitization cause peripheral sensitization? What do you guys think? Just looking at this and having just a really kind of low level understanding of it. Or could maybe even peripheral sensitization cause central sensitization? What do you think? Yeah, right? And that's where we get into this issue of, okay, this is weird, right? Both of these are nerve signals not firing right? Just the main difference is in the periphery, it's more of those smaller fiber nerves. And then once we get back to the spine, we're talking about tracts and brain, which really are going to be hard to kind of process and get out. So altering the way a patient perceives and receives pain can potentially alter their pain experience, right? So patient experiences an event, they go to a medical professional. They go to a doctor, they get prescribed meds. They go to a surgeon, they get prescribed surgery. They go to a chiropractor, they get prescribed bone cracking. And depending upon other types, maybe other less than usual treatments, because some chiropractors also dabble in herbal life and all that fun stuff. Can't really rule out anything exactly, John. Go to a traditional physical therapist, they get prescribed physical therapy. You go to a naturopathic practitioner. I have no idea what the naturopathic practitioner would prescribe for you, but I have an imagination and I can only imagine. I'm not going to comment on it. You go to a psychologist or a psychiatrist and they get told it's all in their head. Technically, that's the most correct answer. But if you just tell a patient right now, so I'm not saying this you go out and what you learn from this lesson is that pain is in their head, and you go tell a patient that pain is all in their head, you're going to have a negative response probably back from the patient. Just get over it. It's all in your head. Yep. Right? Even though it is, it's educating them gradually about that, right? You don't want to necessarily say, just get over it. It's in your head. For those of you that have ever experienced depression and your friend has that great answer to your depression, that is, Well, why don't you just get over it? That's great help, friend. I appreciate it. Why didn't I think of that? Right? That's not the way things work. It's just not the way things work. So we got to talk about the body to the brain and the brain to the body, right? What if instead of looking at the purely biomedical and mechanical, we continue to treat them and in conjunction from the top down and work on the brain? So we slowly add in more and more of that kind of brain knowledge as we're going. We could actually break that pain cycle, and we could alter the patient's perception of pain. In reality, we can alter their life entirely. And I know, I don't know if you guys picked up on this, but I'm actually really excited to teach this topic. And I'm like, my chest is killing me, but I really love teaching this topic. Because I look at this and I'm going, a lot of this is what I learned in the martial arts. It really is. Overcoming pain was a big part of what I learned in the martial arts because, you know, our instructor was a sadistic little old man. I'm just joking. I mean, he did kind of teach us how to overcome pain. But on top of that, by going into the research about this pain, I changed my own life a little bit. So I do believe this can change a patient's life, right? It can even alter the way we practice. And the reason I'm saying this is, you know, I'm just going to use myself for an example here is even with my broken neck being fixed, most days I have what's called chronic daily migraine. So that means every single day of my life since about, I don't know, since about 2003, because they've never found what causes my migraine, I've had a migraine. Now, some of you, I say that and inwardly you're cringing because you've had migraines and you know what they're like and know how they can just totally destroy your life for a day. And then I broke my neck and I added additional pain on top of it. And there for a while after I broke my neck, I was in pretty bad shape. I didn't know if I was going to function. I don't know how I was going to do anything because that was just pain on top of pain on top of pain. And on most days, my migraine exists somewhere in like 6 to 7 out of 10 range. But for the most part, I'm able to function. And it's mainly because I looked into this pain neuroscience and thought, okay, there's more to pain than just what I'm experiencing, right? So how do we use this, or should we even use PNE in the clinic? Well, there's clinical step-by-steps in numerous books. In this case, reading is fundamental, including reading research. An application of this at the clinic is directly proportional to the education you receive. And I'm going to toot my own horn here. I don't know of any other PTA program that's actually doing a pain neuroscience lecture. So I'm going to say you guys are getting a little bit more. It's noticeable people go to CCU courses, right? You guys have seen this maybe when you're out in your clinic rotation, that somebody went to a continuing education course and then they came back, you know, they went to a continuing education course on zebras and they come back and everything's a zebra. Because that's the way it works, right? You see everything in what you just learned. But the key thing with PNE is it's only one phase in helping a patient, right? This is to help change their behavior and they have to be open to that change. The clinic itself also has to be open to making changes. Like Riley said, how do you bill for this, right? Because technically we can't, we don't have the ability to bill for patient education most times. Now, some insurances do allow for patient education billing. And if that's the case, great, use it. Use a little bit of time for patient education, right? But we just keep looking for these clinical application pearls, and starting down the path is only the beginning for this. There's just education upon education upon education for this that will keep moving you. So in a traditional therapy evaluation, we talk about what brings you into therapy, where's your pain, can you describe your pain, can you point to where the pain is? Does this sound familiar? Can you describe what your pain to me? Is the pain constant or intermittent? What makes it better? What makes it worse? What do you want out of therapy? That's pretty much your basic opening to every single visit you have with your patients. When we talk about a more PNE approach, we talk, what do you think's going on with your condition? What do you think should be done for your condition? Why do you think you still hurt? What would it take for you to get better? And this is a big one that I've seen work really well with the patient. Where do you see yourself in 3 years regards to your condition? Well, I'm not really thinking about that. What gives you hope? What is your expectation of me? What do you want from me as a clinician? And if I could take a magic wand right now and Wingardium Leviosa, that's Leviosa, your pain away. I can take this magic wand and wave your pain away. What have you stopped that you would start again? Is that last one kind of powerful for patients? What do you think? Yeah. Because now they're starting to think about, wait, I could do things again? And maybe what you just did was one of your previous questions. Because what you did was gave them a little bit of hope. Because now they're starting to think, okay, what could I do if I didn't have this problem that I have right now? Realistically, I mean, they couldn't say, I want to become Iron Man. I mean, technically you could, but that's really expensive. I want to be Batman. Are you angry at anyone about your condition? That's a powerful question. Right? Let's explore that a bit. Tell me about it. And again, a lot of this, if any of you have had basic psychology or even some advanced psychology studies, this is cognitive behavioral therapy. This is a lot of the way we treat this is one method for treating some mental disorders. Has anyone ever made you feel like you're just faking it or telling you it's all in your head? Guess what we're going to do? Let's explore that a bit. Tell me about it. Does your work lay guilt on you for your condition? How does that make you feel? If you could go do anything tomorrow without pain, what would it be? Now, all of this approach is much more low tech. But I said before, listening is therapy. And you may be the first person to actually listen to a patient. Nothing is above a strictly physical therapist, and nothing in any of these questions is only a PT problem. None of these questions are locked to just a PT saying it. You're not making any assessments. You're not making any goals. All you're doing is becoming a detective. So technically, in this case, you are the pain Batman. You're becoming the detective to go through and try to tease some stuff out of these patients, right? And then we start the pain talk. So we've got broken down some of their walls a little bit. And now we say, has anyone really explained to you why you're hurting? And would you like to know maybe why your pain's not getting any better? And before we start the physical portion of your treatment, can we discuss more about how your pain works and your knowledge of pain? And can we possibly explain why it's so easy for you to suffer in pain? I'm not sure if any of the clinics in the area use this PNE yet, but did anyone see anything similar to this, either watching an eval or anything like that?
There was one PT in my clinic that used PNE. He was trying to get me to do an in-service on it, but it was too confusing for me.
Well, but, here, you've got a whole in-service now.
Yeah. But yeah, he was explaining, what would he would tell them, he used the sunburn as like an example of what their back pain was like. I saw him do an eval on somebody with back pain, and it was pretty interesting.
Yeah, and it is. It's a totally different version of therapy. And I've had really good results out of this, especially in patients that have CRPS. And so then let's talk here, right? So this is, remember way back when in anatomy, we talked about action potentials, right? We had that good old action potential curve. So here's that action potential. Do you guys remember that? A little bit? Right? And our resting membrane potential is minus 70 millivolts. Right? And that's kind of where we are. And then we get that depolarization here. We get the repolarization here. We have our hyperpolarization. And that's kind of the whole action potential process, right? But do you remember back to the anatomy, what happens when you constantly get those low hump signals, those graded potentials? Do you guys remember what happens with that? So remember that usually to fire off, it takes to go about minus 50, so about a 20 millivolt change. Do you remember what happens when you're getting all these graded potentials? It gets harder to fire off that action potential. It requires more of a positive change, right? And not only that, but then it raises that threshold. So if minus 50 was where we were, maybe now in order to fire off, it's minus 90 or no, minus 20. So we're always negative. It can take hours or days in certain muscles and certain parts of the body for that resting potential to return back to normal, where it's only a normal sensation. So that kind of plays into our idea here when we're looking at the fact that patients can get that central sensitization and peripheral sensitization going on, when our membranes and our action potentials get screwed up. Do you guys remember what else can affect action potentials? Outside of just the signal?
Is it isotopes?
Okay, isotopes. Very good, right? Yeah. What are some of the isotopes that are important in sending signals down the nerve?
Now you ask me the hard question.
What are those things called that open and close down the nerve to send it down? Yeah, there we go. The sodium potassium pumps and channels, right? So our sodiums, our potassiums. What's the other one that goes with them? The other ums. I know, it's almost like I planned this in, right, Brooke? There's one other IUM that goes with these. And it's not Valium. Calcium, there we go, right? Calcium. So those all help us, and we also have to have our little INE as well, friend, chlorine. Right? Because what does chlorine do to all of these? It binds to them, yeah, right? Because NaCl is what?
Sodium chloride.
Yeah, it's sodium chloride, it's salt, right? And actually, technically, all of these are salts, right? Calcium chloride, potassium chloride, sodium chloride, they're all salts, right? But that's one of the ones we're commonly see, right? So that means not only do you have to have a little bit of talk with these patients about how that action potential works and stuff like that, but you also have to talk about their diet, right? Because if you have a patient that has a high sodium content or salt content diet, that extra chlorine is going to come in here and bind with all of these and maybe slow down that action potential, right? So we have to have a delicate balance. We have to have some chlorine in our system, right? But we have to have a delicate balance. I'm not telling you to stop going swimming. But we have to have that balance of all these. And what do we commonly call these when we put these in like sports drinks and stuff?
Electrolyte?
Electrolytes. Yeah. What is an electrolyte?
Salt.
Okay, salt, but like even more basic, what is an electrolyte?
Energy?
Not necessarily energy.
Hydration?
It does help with hydration. You're 100% correct. An electrolyte is a propagator of electricity. That's what electrolyte technically means. So when you're taking in a lot of those, like Gatorade has a lot of potassium chloride, sodium chloride, calcium chloride in it, in order to help you return your body to normal firing rates, right? Because you go and you work out really hard, your muscles get what? Sore. Because you've used up a lot of your electrolytes doing exercise. Or you go out for a night on a Friday night and you drink a little too much and your body kind of dehydrates. And so your electrolyte levels are low and so is your just hydration levels, right? That's why I have to laugh that Pedialyte has now fully embraced the I'm going to help drunks recover from hangovers effect. That they have like recovery stuff for after hangovers because they realize that some of the best recoveries for hangovers is Pedialyte. Because mainly Pedialyte doesn't have the sugar of necessarily that all the other drinks have. And Pedialyte's now marketing to adults. Have any of you seen that? They like now have Pedialyte sports drinks for adults, which I just laugh because shouldn't that be like adult light and stop calling it Pedialyte? We're not kids anymore. So in the clinic after starting PNE, they still have to do something physical. So this is much like modalities. PNE is important, but it's only one part of the recovery process. So we got to work on exercise. We got to work on movement. We may have to teach them breathing and relaxation, right? And then they have to have a little bit of a homework program. That means send them with stuff home to read, or maybe sending them home with videos to watch. I actually had one of the previous students who was in cohort, I think 8, asked me, he says, hey, Mr. McKeever, did you ever record that PNE lecture you do? I'd like to show it to one of my patients. And I'm like, I'm a little weirded out that you're going to try to show me to one of your patients, but sure, it's up on YouTube. Like, comment, subscribe, hit that bell. But they've got to have a little bit to do, right? They should have a walking program. Almost every patient should go home with a little bit of a walking program, whether it's 15 minutes, 10 minutes, 5 minutes, whatever it is. They need to put time out of their day to go walking. They should have 2 to 3 basic exercises, no more than that. Any more than 2 to 3 exercises have been shown, the patients don't do them, right? And then little goals every week for them outside of the clinic. So maybe set a goal for them to walk their dog twice a day, right? And then they come back next week and they're like, hey, I'm doing it consistently. Great, let's reassess that goal, right? Let's give them some stuff to do. So looking at pain again, pain is normal. It's okay to be in pain. It's there to protect us, but can also hurt us. And if we can change the way the patient sees pain, it will help them. You know, patients are truly interested in their pain, and they will listen to you when you talk about this stuff. Because I can already tell, and I don't see all of you, but I know that some of you are at least sitting kind of really listening into this actively. And so the idea of PNE is turning down that body's alarm system therapeutically through both education, pain neuroscience education, aerobic exercise, manual therapy, pacing, and then some graded exposure to their problem, right? And that comes with breathing and relaxation. The negative thing that I see a lot of times when clinicians go to take courses on PNE is they're like, well, this is just a hands-off approach. This is just frou-frou, ha-ha, oh, talk therapy, right? But it has to be used in conjunction with normal therapy. The more we listen, the more the patient will provide us with breadcrumbs we need to help them. And if you remember this whole time I've worked with you guys, I've said therapy is safety, therapy is compensation, and therapy is following the breadcrumbs. Right? So we're going to follow them. Education by itself is limited unless there's follow through and the patient wants to follow through. And again, I said education of diet is really important. That means keeping a weekly food diary. I actually just started doing this over the past, I started this on last week. It's been a little worse this week because my food diet has pretty much been tea, soup, tea, soup, tea, soup. That's pretty much what my diet has been this week. But my problem is I do want to lose a little bit of weight, and I've cut out just about everything I possibly can cut out. Honestly, I'm not eating that much. And what I think I've looked at my food diary is I'm actually eating too little, because that can be a problem too. So I'm starting to keep track of my food diary. And we can also help them by doing that, because do we know that some foods trigger inflammation? Yeah, like what kind of foods can help trigger some inflammation? Salt's good. Maybe, right, some really complex carbs, right, Joe? Alcohol. Yeah, specifically what type of sugar though, Joe? Not simple, the other way. Complex, processed sugars. Right? Simple sugars actually, John, like your fructose and your lactose, and well, lactose is when you cut off a foot, right? Lactose. Come on, that was kind of funny. No? Damn, I tried. Yeah, I know, that failed. At least Anthony laughed. I appreciate it, Anthony. But your fructose, your sucrose, and all those simple sugars, and again, in moderation. I'm not talking like just go and dump fructose down your throat. But the simple sugars are a little bit better for us, especially like the fructose is a di sugar versus a micro sugar, macro or a minor sugar versus a macro sugar, and we could go into that for hours. But do we also know that there are foods that tamp down inflammation? What are those foods that kind of help with inflammation called? Because the main goal is to, yeah, veggies do, okay, good, right? The main goal is to cut down on the oxidation in our body. Antioxidants, good, right? I usually, when I say what are some of that usually inflammation, the first thing I usually get is blueberries. Has anyone heard that before? Like actually a lot of the berries, blueberries, boysenberries, lingonberries, all those type of berries have really good antioxidant effect. The downside to usually eating a lot of berries is, well, you'll also be very regular with eating the berries. I'm just saying. And also, if you eat a lot of vegetables, Brooke, you'll probably be pretty regular too. Pomegranate, there we go, good, right? So eating those things that are good for us. And I'm sorry, I know I'm gonna make somebody mad in here, but even eating some animal protein has been shown to help reduce that a little bit. Some, or at least increasing your protein intake, if nothing else. So going for more of the nuts, your veggies that are heavy in protein and stuff like that. I still don't like kale. I don't care what none of you are ever going to get me to eat kale. It's not going to happen. Right? So that means that food is important. Hydration is important, right? Especially hydration when it comes to water. So that means drink lots of Bud Light. I'm just joking. That's a joke. But water is important. So drinking just plain water. And I'm going to be honest, I am bad at that. I don't know if you can tell. Some of you have called me out on it already. I'm really bad at drinking water. I don't know. I don't like water. Even if it's like bubbly water or flavored water. Nope, it's not out of your scope of practice to talk about nutrition. As long as then in the end you kind of say they need to kind of look at nutrition from either a nutritionist standpoint or go and see a dietitian. It's not out of our scope of practice to talk about nutrition, right? Especially if you're educated. The downside is don't go like total like conspiracy theorist on nutrition either. Does that make sense, Anthony? Because you can go that way. You can start going down that conspiracy route with nutrition as well. Yes, there we go. Not certain products and supplements. Yeah, right. So we're not going to recommend Herbalife. And also, guys, just as an aside to that, because that brings it up. If you are, and I'm not saying it's bad to be a representative for Herbalife or those, I forget those shake companies are, but all those things. It's not bad to be a member of those companies, but you cannot push those while you are at work. That is a direct violation of your license. So you can't be sitting there saying, well, hey, I've got this St. John's wort over here from Herbalife, and I'm just picking Herbalife because Herbalife is one of the ones that's been in the news before. There's nothing wrong with Herbalife. Please do not sue me, Herbalife, if you watch this video. You just happen to be the person I think of when I think about stuff like this, right? And then reintegration in normal social function is also important. Getting them to get out there and put themselves out there is important. So how do you do it? What do you have to lose? Try it, right? Hold your patient's hand, be there, give them STDs, show, tell them, do them, right? I said that yesterday with the other class, and they're like, I was watching them on stream, and several of them are like looking around. Mr. McKeever's telling us to give patients STDs? I'm really confused. So have them show, tell, and do it, right? Provide regular and consistent feedback, but change your feedback techniques. So maybe do some of that summed bandwidth and regular feedback, right? Make adjustments based upon your feedback and your patient's feedback. Discuss new sensations, relate them back to PNE. Oh my God, I'm starting to get a little bit of soreness in my hamstring. Relate that back. The more you can relate stuff back, the more it sticks. Every session, ask about their HEP, not just their exercises, but also their journaling and their logging. Integrate the HEP into their ADLs. Make them appropriate for what they do, right? So here are the 10 pearls for pain neuroscience education. You have to be smarter than your patient. I feel like that's a given just for being a clinician, wouldn't you say? That you have to be smarter than your patient. Education should be paced. I know this is not the way to educate your patient on PNE, a 4-hour dump session, right? You need to stage it and pace it. All you can do is plant the seed. And that's what I'm doing right now with PNE with you guys. I'm not saying this is the end all. Maybe, we could find out down the road there's something better than PNE. Great. But I'm going to plant the seed and say this is actually some pretty cool stuff. And I hope that some of you think this is some pretty cool stuff. Don't force it, but also look for back doors. When they, maybe they don't want to hear this, but at some point or other, maybe something they do will trigger them to want to do this. I use this a lot, and that technique there I use a lot when I'm talking to flat earthers. Because my ultimate goal when I'm talking to flat earthers is not to humiliate them. I don't have to do that. My goal is to bring them back to reality, that the earth is a globe. I'm sorry. Tether your treatments together. Set boundaries for your patient and for you. That means they always need to be on time. Don't miss your appointments. Do your homework. If a patient is a patient that regularly does not show up on time, what should you do? And this is counter to most clinics. Your patient that's scheduled at 3 o'clock every day, and every day they come in at 3:30. What should you do?
Change your appointment to 3:30?
Okay, change your appointment to 3:30 is one way. But the problem with that is then what's going to happen?
They're going to come at 4.
Yep. Give a consequence. Yeah. Charge them. Talk to them about it first, right? Alex is right. First of all, talk to them. Tell them how they're coming at 3:30 is not only affecting, because if you say it's affecting me, they don't care, right? Alex goes to the patient, man, you're making my job hard. The patient's going to be like, I don't care. They really don't. I mean, so there may be a few that would, but for the most part, they're going to be like, I'm paying you, right? But talk to them first. Say, hey, this is affecting our clinic. This is also affecting your therapy. You're not getting the most out of your therapy. Stephanie says, charge them. I've done that where I've refused to see them and given them a cancel appointment fee. That is by far the most effective treatment I've done for this. They come in at 3:35, their appointment's at 3. I'm sorry, I can't see you. I have a booked appointment. You're going to have to reschedule at the front desk, and this is going to be considered a cancellation, and there's a $25 cancellation fee. All of a sudden, they stop coming late. It's kind of interesting the way that happens. Yep, NSF fees too. Yep, there you go. So just make sure you it's right. It's not much different from that, right? But that also means that if they're going to be on time, you have to be on time. So you have to expect the same expectation of yourself, right? And if you're going to get back to them about something, like maybe say, hey, I'll email you later today about this, do it. That fosters compliance. Patients are smarter than you think they are to a point, right? We still have to understand average education in Nevada, 7th grade education. Pain is real, even if it's in their head, but also remember it's subjective. The more detailed the homework, the more breadcrumbs you'll have. And movement is still the best painkiller in the world. Motion is lotion. So the more they move, the better they feel. So eat your move with every meal. So here are just a couple books that I really recommend. I put these on the PowerPoint, and honestly, if you can read these, a lot of these have changed my view on things. Of them all, these two books over here have by far changed the way I think about the brain the most. The Brain That Changed Itself and The Brain's Way of Healing, which are both neuroplastic books. This book over here, The Why Do I Hurt? By Adrian Lowe. If you look, most of them are by Adrian Lowe that are pain. And then A World of Hurt, I think, is by Kulski. Yes, Kulski. This Why Do I Hurt is written for patients. So in the clinics I've worked at in the past, I bought about 5 of these. I think they're only like $9 or something like that. And I keep them on a shelf in my area. And I'll loan them out. Now I have had patients not return them. And then I just go, what's $9? I'm out $9. But I loan them out because that book you can read in a night if you really wanted to. I forget how many pages it is. It's not that much. But it really does kind of go into the basics of why a patient hurts. And it goes into the basics of pain neuroscience. And then if I have a patient, I start them on that. And then if they have the back pain, I move them to this book. Everyone has back pain. And I found that the patients that read these two books, I really get good results out of. This book's a little bit higher brow, so it does require a little bit more thought process when you're reading it. The Brain's Way of Changing Itself and then The Brain's Way of Healing are both really, really good books, I think, from a clinician standpoint. I remember the first time so I actually have a signed copy of The Brain's Way of Healing, or The Brain That Changed Itself, somewhere over here, that was given to me by my CI way back when dinosaurs roamed the earth. So this has been out for a while. And he does have a PBS special called The Brain's Fitness Program, which is actually kind of interesting too. But I read that one and I took a while for me to read it. Gave you that book too, Stephanie? Yeah. I love the book. I go back and I reread it. It's not like it's the one that I just put on the side. It's almost like some of the other ones, like The Anthropologist on Mars, that I go back and read as well. The Brain's Way of Healing, when it came out, I finished that book in one night. It's a thick book, but I really like it. I devoured it. It was just so interesting because what Norman Duhigg does, Dr. Duhigg, is he'll give you case examples of patients. And it's really cool to read through on the different ways like vestibular patients are treated and stroke patients are treated. And it's not only from the American standpoint, but I think he's Canadian actually, so we've got to forgive him a little bit. But it's just they're all interesting books. They're all relatively inexpensive. I'd really recommend you reading it. It's not a requirement for this course, but I really recommend you reading them. All right, I'm going to get out of this and we'll go into questions. Are there any questions on that lecture? Did it interest you at least, some of you? Did it trigger some thought processes, maybe? Yeah, it's still hard to wrap around. You're right, Brooke. It's not something so I do not expect you to be an expert at this. I don't consider myself an expert. The only thing I'm an expert at is consuming coffee. That's about the only thing I'm an expert at. Right? That is literally about the only thing I consider myself an expert at. And I don't even care if it's good coffee or bad coffee. I'll consume it. But what it does is it really kind of, I hope this concept triggers you go down a path where maybe you think about pain a little differently. Even if you don't start applying PNE, you don't have to. But it makes you think a little bit more when you have those patients that are really rough, especially those chronic pain patients. Because I'll be honest, out of all the patients I work with, or I've worked with, because I'm not working right now, obviously, because otherwise, I can't see you guys. Out of all the patients I worked with, chronic pain are always the most challenging for me. Because I really believe they start feeling like nothing's going to ever make them better. And so they take on this mindset. And there are some really good chronic pain physical therapy clinics in town. Don't get me wrong. So I think truly people do. I mean, I'm going to be one of those people that I don't say it out loud that I have a high pain tolerance, but I believe I have a high pain tolerance. And I don't think it's because like I can resist pain any better than anyone else. I think it's because I understand pain better. Does that make sense? So I don't think it's like the same as somebody that says they have a high pain tolerance. And I'll say, if you've got somebody that's been in the military or even in the martial arts, they do tend to have a little bit higher pain tolerance. They also have a little bit higher tolerance of bullcrap as well. That's beside the point. In reality, I think sometimes when people say they have a high pain tolerance, they don't understand pain. Right? Like, I forget which one of you said, but what about birth? Right? Because birth is pretty painful. I'm not going to lie. If guys had to give birth, I guarantee that I'm going to say that this human species is probably going to fail, because women do tolerate a lot more during birth than most men tolerate. I'm just going to be honest. I joke about that a lot when I see patients that have had total knee replacements and total hip replacements, that my little old ladies usually do better than my little old men. You agree, Stephanie, right? Yeah, especially if you got middle-aged men that get total knee replacements. I'm gonna be honest, like guys that are in their 30s and 40s that get knee replacements sometimes are the biggest babies. So there is a kind of a threshold for that. I do find that women that have had babies or have had children before experience pain a little differently, I think. And I'm not exactly sure why that is. I'm sure there's probably research on this. But I find they're more willing to push through pain a little bit more. And I think it's probably because of giving birth. But in reality, why do women go through pain with birth is just because they're trying to eject a watermelon out something the size of a hole the size of a lemon. That's really why. And I can't imagine what that does to the body and the pain that goes through that body and the pressure on all the nerves and the peduncular nerve and the sciatic nerve and the obturator nerve and everything in that area that we know could get compressed. Right. And then everything goes along with it. If they get a tear and get episiotomies. Yeah. When my first goddaughter was born, my friend who had the baby was like, I'm going to have it all natural. I'm going to have it all natural. And then the contractions kicked in. And she grabbed my hand and she just screamed at me and she's like, drugs, give me drugs. I'm like, okay, please stop breaking my hand. I know you're like 80 pounds. It's an amazing event. And story about that, when my goddaughter was born, the doctor, baby came out and because I was the alternate for the birth. My friend wasn't able to make it. Her husband or boyfriend at the time. And the doctor takes the baby. He's like, would you like to cut the umbilical cord? And I'm like, isn't that what we pay you for? No, I'll stay up here, north of the drapery. Otherwise, Mr. McKeever might pass out. I'm just saying. But yeah, so I don't know. I think, especially in birth, and I've seen it or heard about it at least, is that there's a combination of both that pain and the euphoria, right? Because, I mean, you're giving birth to another human being. And it's just, I don't know, it's amazing. And then it's amazing how the body then, after birth, releases chemicals to calm the mom down. To me, that blows my mind. I don't know. That's the neuroscience stuff that's really cool to me. That our brain knows how to do that stuff. Yeah, right. It's just, I don't know. It's crazy. It blows my mind. And I especially like my mom, I feel bad for her because when I was born, I was 12 pounds, 8 ounces. I do not know how she had me. I'm basically a 1-year-old. Yeah. Like, and then my older brother was 12'10". So we both were big babies for mom. And I had an RH compatibility factor with my mom too, which was kind of wild. But yeah, so I don't know. Pain's interesting. And I don't think telling a mom that's giving birth that's all in your head is going to work. I'm just going to be honest. That might not be the time for pain neuroscience education, guys. So, like, Truman, Anthony, once you get a wife and you guys get kids or whatever, probably not the best idea that in the birthing room to start talking about pain neuroscience education. I'm just saying. Only if you want to get beat up. Right. I think the ladies are speaking here, guys. I'm just going to leave it to their expertise. But it's kind of wild. I don't know. All right, I'm going to stop recording because that's it for this lecture.